Of SSBMT meeting. Today we'll have a couple of presentations. We'll start by Drs. Rafael Duret from Spain. Dr. Duret is the head of Department of Hematology and Director of the Stem Cell Transplant Program at Unit of Hospital University at Puerto in Madrid, Spain. Dr. Duret earned his medical degree in 1992, then PhD in 1995 from the University of Córdoba in Spain, specialized in hematology at Hospital Romain Y Capital in Madrid in 1998. He completed postdoctoral research fellowship at Harvard Medical School, then at Harvard Cancer Center Institute in Boston in 1998 to 2000 at the Royal Free Hospital. He's a consultant hematology at Kent College in 2004 to 2005, and prior to his current position, head of division of myeloma and leukemia and stem cell program in Catalan Institute of Oncology in Barcelona, Spain, at 2015. Dr. Duret is on a fellowship at Royal College, and he is one of the top scientists in the world, 1 out of 1,000. He has been a long-standing member of EBMT board as a chair member and a chair member for Transplant Complication Working Party. He was also president of EBMT annual meeting Congress in 2020 and 2021. He also a member of CIBLT Advisory Committee. Dr. Rafael is going to present today a topic about emerging treatment and prophylaxis for the viral infections.
So thank you very much. Good morning everyone. Thank you very much for the kind words of introduction. I will share my screen now. And first and foremost, I would like to thank the organizers, the Saudi Society, for the kind invitation, and also Ms. Noor Kaya for so kindly arranging things so that I can join virtually in this occasion. And I apologize that I can't be there with you in person. Over the next 25 minutes or so, I'm just going to try and share with you some of the emerging therapies and prophylaxis for viral infections that we have in our immunocompromised transplant recipients. In reality, I'll only highlight that being an investigator, one of the people involved in the development of both letermovir with MSD and with Merck, and maribavir with Takeda for CMV infection, part of which I'll mention in this talk. I'll start with something that I think was quite revolutionary. Shingrix vaccination and zoster. And we know that this is an abstract that we presented with some experience, Ana Bocanegra, one of my consultants, examining our experience with Shingrix vaccination in allogeneic transplant recipients, because as you know well, varicella zoster is still a high risk in transplant recipients for infection and reactivation. And although it's not one of the most lethal, severe, but it can be actually quite a burden in terms of symptoms. And the standard management we've done for decades is just acyclovir prophylaxis in these patients. A new adjuvanted recombinant zoster vaccine, Shingrix, has been shown to be effective in immunocompromised older adults and in autologous transplant recipients. And as a result of that, the approval in most places, including my own country, is actually extended not only to autologous, but also to transplant recipients overall, to allogeneic as well. One of the beauties of the Shingrix vaccination is that in autologous transplant, the scheme for administration, the timing of administration is very early on. It's in the first 100 days after transplant. But of course, the level of immunosuppression that autologous and allogeneic transplants have is very different. So there's always been concern and not very clear evidence that the vaccine is immunogenic at all in allogeneic transplant recipients. There's a number of prior studies, which are indirect studies, no proper trials in allogeneic transplantations that suggest that. So we just looked retrospectively to our early experience in just a handful of patients. Primarily, we looked at it because we did face a number of breakthrough zoster infections in these patients. Small group, 17 patients, and that's the demographics. And I wouldn't go into much detail. That's like the standard patient with allogeneic transplant recipients that we use, around 40+% of acute GVHD and chronic GVHD. And we vaccinated all those 17, 13 of them, 3/4 received the full vaccination schedule with 2 doses. About half of those 8 patients were still receiving prophylaxis. We give prophylaxis for the first year after transplant, receiving prophylaxis at the time of vaccination, and then prophylaxis was subsequently stopped. And then the rest of them had already finished that first year, and then we just vaccinated with Shingrix along when they came back from other vaccines to the department. Following vaccination, in terms of serology, 8 cases either seroconverted or increased the pre-vaccine titer of anti-zoster immunoglobulin. There's a few, however, that didn't quite respond. So overall, at least the results seem to be encouraging in terms of tolerance. However, from a clinical perspective, we had 3 cases out of this rather small group, around 8%, that presented a zoster infection. That was at a median of 8 months after transplant, and those were all after discontinuing acyclovir prophylaxis. There was 2 monometameric, and there was 1 fairly complex multimetameric zoster in one of these patients. Of course, these were patients that were particularly immunosuppressed patients with ongoing intestinal and skin GVHD. In 2 of these cases, in particular, the one with the multimetameric. And patients, in any case, good things is that they could be easily treated and successfully treated with acyclovir. However, this brings a number of questions. Primarily to us, we need evidence that really shows that the immunogenicity of the Shingrix vaccines extend to those 2 doses, extend to allogeneic transplant recipients. So real life experience, albeit very small, because it was just a sort of like a flag, a warning, is something that shows that up to 18% of these patients can have it once you stop acyclovir. And even though of course, the vaccination doesn't necessarily come with the need to stop acyclovir. Honestly, if we have always managed to control this with just acyclovir low dose prophylaxis, it wouldn't be of much use vaccinating all these patients if we're going to have to remain on acyclovir prophylaxis just the same. So I think this is something, at least a word of caution for you guys to think about it when you plan the vaccinations in your own centers for your allogeneic transplant recipients for zoster. Second point I wanted to move on and continue with the herpes viruses with herpes simplex is pritelivir. Pritelivir has come up as a new antiviral drug, a helicase primase inhibitor for herpes simplex, and in particular for resistant herpes simplex. We all use acyclovir for prophylaxis of this after allogeneic and autologous transplantation. We normally do long term, at least 1 year. But in patients that for some reason don't receive it long enough, the occurrence, the emergence of resistance is not rare. It can occur. We are already starting to get information that is not only in the general population, but specifically in acyclovir-resistant herpes simplex infections in immunocompromised patients. This is a small study with 23 immunocompromised patients, including both HIV and oncology patients, showing that pritelivir is well tolerated. There's a loading dose of 100 milligrams and then 100 milligrams daily for 28 days, so that's 4 weeks. And the good things, and I thought that might be useful for this group, is that it's available outside of the trials. There's still phase 3 trials running, but in addition to that, the drug can be accessed through IQRIS, which is the company that manages it as a special situation compassionate use program. We've treated 2 patients very successfully, very well tolerated, and we've had both genital herpes in a female patient and a esophagus and mouth herpes simplex refractory as well to acyclovir that we've successfully treated with pritelivir. So just to make you all aware of this data and the availability of the drug. Brincidofovir is a very important drug that sort of like we've lost for a few years, that that we even had big trials in prophylaxis of CMV with brincidofovir years past, and that had a number of challenges in terms of administration, in terms of tolerance, in terms of the results. So the drug moved on to the field of adenovirus, with definitely it's one of the most challenging infections in heavily immunocompromised patients. And then Michael Grimley and collaborators, Michael Boyd and collaborators, presented this at ASH last year. It hasn't been published yet, but at least I'll give you an idea of what it's happening. Brincidofovir in an IV formulation is safer and better tolerated than the oral formulations that had gastrointestinal and liver toxicity. So that is an additional new formulation that is making this easier for the drug. Is highly effective, and it was actually leading in this, which is still a small study, but it led to a very rapid clearance of adenovirus viremia in all subjects and sustained virologic response. So brincidofovir is coming back. It's coming back in the adenovirus field in our transplant patients. It's something that you need to keep your attention, and hopefully the paper, the manuscript, will be published soon as well. And I want to then go now into cytomegalovirus and go in at least 2 or 3 lines of what we're doing with this. We've spoken about for talk of treatment and prophylaxis with Simpson treatment. I wanted to even include some vaccination strategies for prevention. And that we had a couple of big flops of the Vical vaccines. This is the initial trial in kidney transplant recipients that was completely negative and no benefiting in renal transplantation. We also had a trial for recipient vaccination with the Vical vaccine in allogeneic transplant recipients, the Helios trial, and that unfortunately was also a negative trial. So it's an area, it's really a challenging area, and I think it's something to be praised that other groups, and this is a group from Duke, in City on Hope National Center from City on Hope that Ryotaro Nakamura at the tandem a couple of years ago, and now Corina La Rosa, who's the first author, retired as one of the senior authors, developed this CMV triplets vaccination and directed to stem cell donors, not to the patients, but to provide a protection against CMV coming from from the cells, from the immune system, from the donor. Overall, we know that the incidence of CMV has overall reduced a lot as a result of letermovir prophylaxis. But it's true that letermovir prophylaxis leads to a delayed immune recovery. And as a result of that, we get less infections, but all those infections happen later in time when the immune system has not been strongly activated to protect from infection. So this is a pilot trial. It's a pilot trial with a recombinant modified vaccinia Ankara viral vector, including PP65, which is the commonest, IE1, IE2. And this had been previously shown to be safe and immunogenic in healthy volunteers and transplant recipients. So they went now on to use it in donors. That's a series, 17 donors and recipients, so still small pilot trial. Donors were vaccinated once, and they were vaccinated a couple of weeks before transplant. Median day 15, range 11 to 28 prior to stem cell collection, and then in the stem cell product collection to all these peripheral lymphocytes that would have been prime activated with the vaccine against CMV. And this is the information. You can see here on the left-hand side on day 28, the bars on the panel on the left is CD8, the panel on the right is CD4s, and you can see that there's a clear increase of the number of T cells specific against CMV, CD4s, and CD8s compared with unvaccinated cohort. So the higher bars are the T cell against CMV that vaccinated donors have and how they develop in the patients. And not only that, panel B, you can see that increase early on actually carries on over time up to a year after transplant. So these cells that are adoptively transferred with the cell product and peripherally expanded in the donors continue to expand through the first year. And then they're primarily central memory and effector memory profile. So the summary of what we're getting here is that very clear increase in CD4 and CD8 CMV specific T cells day 28, that they continue to expand during the first year, and that also they have a particular functional profile of CD4 and CD8 T cells. All these recipients engrafted with full donor chimerism in myeloid and T cells. The rest of it happened as it would normally happen in transplant. They did something else interesting, which was to see how much of that expansion really came from the cells that were adoptively transferred. So they looked at specific anti-vaccine antibodies to see that expansion. And they could see here in the red color that there was an increase on those CMV specific, and that those associated very clearly with the increase in vaccine specific CD8 T cells. So that was adoptively transferred anti-CMV immunity in those patients. The vaccine was well tolerated overall, minimal injection point symptoms. And then something that is very interesting is that out of those 18 recipients in the trial, 15 patients received no prophylactic letermovir, with only 3 cases of CMV viremia overall in the long 1-year follow-up. So we're talking about 3 out of 15, which is around 20%. So it's still small numbers, but clearly there's a strategy here by which we might have a promising way to enhance immune transfer and reconstitution of CMV-specific T cells, and at the same time spur, to some extent, the use of antiviral prophylaxis, or at least the long-term use of antiviral prophylaxis, and preventing prophylaxis from having a negative impact on the anti-CMV immune reconstitution. And I'll finish with a couple of studies on Mariovir. Cytomegalovirus has had for the longest time established treatment first line with conventional DNA polymerase inhibitors with oscarnet and anciclovir, valganciclovir. There's new drugs, and I just mentioned in passing letermovir, which we've had already for many years, so I won't go into detail there. But maribavir is an interesting drug. It's a drug that's a specific UL97 inhibitor. So it adds at different levels, replication, maturation, egress of viral capsids. I've been involved in development of this drug in CMV in two main trials. I'm going to speak first about the maribavir used for refractory with or without resistant CMV infections in transplant recipients. Maribavir was administered, was a randomized trial, 2-to-1, was maribavir treated for 8 weeks, 400 milligrams orally twice weekly, and then compared with investigator-assigned therapy. That was primarily valganciclovir, anciclovir, and foscarnet. A little bit of cidofovir was the cidofovir as well. There was a rescue arm for patients who failed to respond. And randomization here at the bottom, I think it's important. First is randomization stratified by transplant type. So on the one hand, allogeneic hematopoietic transplant, and then on the other hand, solid organ transplant recipients, and also was stratified depending on the CMV DNA level, less than 910 to 910 to 9,100, 9,100 to 91, or over 91,000. The primary endpoint was confirmed CMV clearance by week 8, and a secondary endpoint was that the not only achievement of that clearance by week 8, but the maintenance of that clearance without CMV symptoms or disease by week 16. So those are results. As you can see, maribavir compared with the investigator-assigned therapy clearly improves the viremia clearance by week 8. Just a difference of nearly a third of patients, 32.8% in favor of maribavir. And then when we look into a number of subsets and subgroups and sensitivity analysis, it reproduces all across the board. I'm going to just show that to not take too much time in this forest plot, and you can see here that independently from the age, from the gender, from the regions, for type of transplant, solid organ versus hematopoietic, of which the investigator assigned drug was, whether it was vanciclovir or foscarnet, all these, viral load, doesn't matter whether it's very high or it's lower, it still does the job better. And the one thing that was perhaps a little bit of a hiccups here was that we could see that was very clear in patients that did have resistance and also have a mutation, but it didn't seem so clear in the group of patients that had the resistance the refractory clinical refractoriness, but did not confirm a virology resistance. That's something that I'll go into a bit more detail. Secondary endpoint, which is that maintenance through week 16, clearly is also in favor of maribavir, and you can see week 12 and week 8, which is primary endpoint, but week 12, 16, 20, all having stopped maribavir on week 8, and still that benefit remains as far as week 20. So clearly a study that met its primary endpoint. This is already approved, and we're using it in clinical practice in many countries. Also, the persistence of the response, not only at week 8, but also at week 16. Overall, the side effects are well established. That maribavir's main problem is dysgeusia, and however, neutropenia, anemia, hypokalemia, all the renal events, that's significantly higher in patients receiving foscarnet or ganciclovir, valganciclovir, including the high proportion in these latter patients of the study drug discontinuation. I'll just give you a couple of slides to summarize this issue of the difference between resistance, refractoriness, clinical refractoriness, and antiviral resistance. This is the same image that I gave you before. So what I did is that we went back to look into, because in the primary trial, the results were central lab results, and they didn't always match well with the results by investigators. So we looked into this, I think, and then according to investigator sites, that then we have 347, pretty much 100%, 99% of all the patients in the central lab, we missed a significant proportion of those. Here, clearly, those reported as resistant and reported as non-resistant have very similar difference and is statistically beneficial, improve response with maribavir, regardless of the resistance reporting. Not only that, we looked as well at those, but excluding those, according to the investigator sites, but in those in which the result was discrepant with the central lab, we took those out. And even taking those out, and that goes down to around 83% of the patients, still keeps a statistical significance in the difference. And then we looked as well at an additional analysis, just looking at the patients not included in the subgroups per resistant according to the central lab. And you can see that the difference is also very marked, 72% versus 21% in favor of maribavir. So overall, as the indication, as the label reads, is to be treated first line, second line in refractory patients, regardless of the resistance status, which for the most part we will not get for at least another week or 10 days. That's what happens in most places when you send these resistance studies. So overall, it's fully consistent with the primary endpoint of the SOLSTICE trial, and I think that it caused. I mean, this has been a big step in the field, the availability and use of maribavir in clinical practice in patients with refractory CMV. And I'll finish with this other study, the last 2-3 minutes. Again, the team of investigators that did the SOLSTICE, many of us were involved as well in this Aurora study, which is maribavir for CMV first line in allogeneic transplant recipients. And you can see this is a randomized double blind. The other one was an open label study, a randomized phase 3 trial, randomizing patients between maribavir and valganciclovir, as you can see here, for 8 weeks at first CMV infection. Maribavir, in this case, did not meet its primary endpoint compared to valganciclovir. And you have there the level of clearance, 77.4 and 69.6, that happened with valganciclovir and maribavir at week 8, which was when the primary endpoint was defined. If you look at the kinetics of it, you can see that here at week 8, as you can see, valganciclovir is that 7.3 or 7.4 difference of result. And however, from week 10 and onwards, they perform just the same once the treatment, because the treatment phase was 8 weeks, once that's finished. So negative primary endpoint, but still consistent with the good experience and results that we can see with maribavir in these type of patients. The main difference between these two arms of treatment was in terms of safety and tolerance. You know that nausea and dysgeusia are the commonest side effects for maribavir, but clearly cytopenias, neutropenia in particular, 63% with valganciclovir versus 21% with maribavir. And then treatment emerging adverse events that lead to premature discontinuation of therapy, also 17.5 with valganciclovir, was only 4%. So in terms of efficacy, the main conclusions from the Aurora trial were that first, the study did not meet the primary endpoint of achieving a superior CMV viremia clearance with maribavir, and that's at 8 weeks. However, a comparable number of patients maintained the viremia clearance and symptom control in weeks 12, 16, 20, with also less side effects. I'll go to safety, less side effects, in particular less neutropenia that the patients with valganciclovir had. Looking at this retrospectively as one of the investigators of the study, of course, if you're going to randomize a study like this against valganciclovir in first line, you need to select all those patients that have a primary CMV at first CMV reactivation, but that do not have cytopenia. So the population treated in this trial is just a selected group of patients who were very fit and at the same time didn't have neutropenia, you have cytopenias, you have thrombocytopenia, and those are patients that could be in a double-blinded fashion, be randomized to valganciclovir. At the end of the day, this was the right design at the trial at the time, and it probably achieved to see a big difference in everyone. However, perhaps in real use as clinicians ourselves, our real need and use of maribavir would not have been for everyone that counts. For that, we were established with valganciclovir and ganciclovir, but perhaps for that rather good size group of patients that we face early CMV reactivations and that have cytopenias, have neutropenia, have thrombocytopenia, and patients that we don't feel like we can really use valganciclovir to treat. So still there's field and there's an area for this drug to be also of service to some of our patients, even in first line. So I'll finish with this and I think I've covered at least prophylaxis, vaccines, and treatments for a number of viral infections, more trying in a group of experts like yourself to at least highlight key things that are coming now. Pritelivir is out there, brincidofovir is going to come soon in adenovirus, and be aware of the vaccine, of the Shingrix vaccine in allogeneic transplantation, and try to at least take a look at your own experience and CMV beyond letermovir initially. Now there's new things happening. The vaccine for donors is, I think, it's a very elegant approach. It's already published and hopefully it'll be developed in a bigger type of study. And then maribavir has come to the field to help us in refractory patients for sure, but also hopefully in patients in which beyond the design of the study early on have cytopenias and we cannot manage with other drugs. Without anything else, I'll stop here and I'll be more than happy to take any questions. Thank you.
Thank you, Rafael, for this.
I'm going to stop sharing.
Thank you for this comprehensive presentation about emerging treatment and prophylaxis for viral infection. We'll keep the question at the end of the session.
Okay.
We have the second speaker now, Dr. Anna Sueda. She's the head of clinical hematology and department in the Institute Català Oncological in Barcelona. She has previously been senior consultant in hospital in Barcelona from January 1991 to 2010. She's focused in lymphoma and hematopoietic stem cell transplant. She is also a focused career in clinical investigator into treatment of Hodgkin and non-Hodgkin lymphoma and multiple myeloma. She has also experience in novel therapy, such immunotherapy combined with stem cell transplant. Anna served as appointed as a chairperson of the Lymphoma Working Party in EPMT from March 2004 until 2010. She also elected as co-chair of the Lymphoma Committee at the Center of CIPMTR and served the organization from 2015 to 2019. Dr. Anna Sorede is the president of the Hispanic Society of Hematopoietic Stem Cell Transplant from March 2022, and she is also president of the PMT. Dr. Anna will going to present about the role of allo stem cell transplant in lymphoma in 2024.
So good morning, everybody. Thank you very much for the kind introduction. I hope that you can see and hear me well. Let's see if I can share my screen. Okay.
Recording in progress.
Okay. So thank you very much once again for the kind invitation. I hope that you had a very nice day yesterday. And in the next 25 minutes, I will try to discuss with you the role of allotransplant in patients with B-cell lymphomas in 2024. So these are my conflicts of interest. And I would like to start my presentation by saying that I hope that everybody would agree that allotransplant is a curative treatment strategy for patients with lymphoma. And we have been using allotransplant for many years to try to cure our patients with relapsed refractory disease that have failed more conventional treatment strategies. This is a rather old paper already published in 1991 that demonstrated that the curves for both progression-free survival and overall survival have a plateau. And this is due to the existence of a graft versus lymphoma effect, but unfortunately, allotransplant is also associated to a very high non-relapse mortality. And this is one of the reasons, together with the advent of new treatment strategies, as we will be seeing later on, that has made the number of allogeneic stem cell transplantations significantly decrease over time. And here you have data coming from the EBMT registry, and you can see that the numbers of allogeneic stem cell transplantations have significantly decreased, basically from the late 90s and starting in 2020. If we have a look at the last publication on the EBMT survey by Baldomero in BMT 2024, we still have to acknowledge that non-Hodgkin lymphoma constitutes the second indication for autologous stem cell transplant, although this situation might also change in the future. And allotransplant or non-Hodgkin lymphoma has always constituted a minority indication for allogeneic stem cell transplantation. As you can see here in this slide, only 5.2% of the patients that received an allograft because of non-Hodgkin lymphoma. So with this kind of historical background, I'm going to divide the agenda discussing the role of allotransplant nowadays in patients with aggressive B-cell lymphoma, in mantle cell lymphoma and follicular lymphoma. I'm going to leave aside T-cell lymphoma. T-cell lymphoma is probably the histology where new drugs, as we don't have them so much, have significantly less impacted in the role of not only allogeneic stem cell transplantation, but also in the role of autologous stem cell transplant. So let's start with aggressive B-cell lymphoma. These data are also coming from the EBMT registry. And here in blue, I am depicting the numbers of patients that have been reported to the registry per year from 2010 to 2023. But let's take 2024 because of an autologous stem cell transplant. And in orange, you can see the number of patients that have been allografted. And as I have highlighted in this slide, in the last few years, we have seen a significant reduction in the numbers of patients being allografted, so less than 37% in the last few years with respect to what we were doing in 2010. And this situation kinds of mimic with the increasing CAR T-cell activity that we have had in Europe, and these are the numbers as reported to the EBMT registry. The EBMT registry started the collection of CAR T-cells in mid-2019, and nowadays we have to say that we have around 10,000 patients reported, and you can see the significant increase over the last few years. And as everybody knows, the major indication for CAR-Ts is relapsed refractory aggressive B-cell lymphoma that have failed at least 2 prior lines of therapy. So these are the 3 constructs that have significant differences in terms of structure. And of course, this led to some differences also in terms of efficacy and toxicity that were approved several years ago by the FDA and by the EMA on the basis of the results of 3 pivotal phase 2 prospective clinical trials. ZUMA-1 gave the indication to oxycaptagene, the Juliet trial gave the indication to Tisacel, and finally the Transcend trial gave the indication to lisocabtagene. And nowadays we have the long-term outcome of patients included in these 3 prospective clinical trials. And we can say that autologous anti-CD19 CAR T-cell constructs are a curative treatment strategy for patients with aggressive B-cell lymphomas that fail at least 2 prior lines of therapy. So here you have the 5 years follow-up of patients included in ZUMA-1, and we have a 5 years progression-free survival, which is a little bit higher than 30%. Here you have the 40 months follow-up of patients included in the Juliet trial, also with a progression-free survival that it's around 30%. And the newest trial is the Transcend trial. And here I'm showing the 2 years follow-up of patients included in this trial. But basically the summary is that CAR T cells are a curative treatment strategy and that have significantly improved the outcome of this patient with relapsed refractory disease, taking into consideration the historical or standard of care treatment strategies that these patients had. So this has been one of the reasons why the numbers of allogeneic stem cell transplantation have declined over time, but we also have to take into consideration the advent of bispecific monoclonal antibodies. And here I am highlighting glofitamab and epcoritamab that have received approval very recently by the FDA and by the EMA to treat patients with this specific situation. This is a landmark analysis coming from the phase 2 pivotal trial of glofi monotherapy in patients with relapsed refractory aggressive B-cell lymphomas. You can see that response at the end of treatment significantly impacts both progression-free survival and overall survival. Those patients that achieve a complete remission at the end of therapy have a significantly better median progression-free survival and median overall survival with respect to those patients that only achieve a partial response or they don't respond at all. And here you also have the long-term follow-up of patients included in the EPCOR NHL-1 prospective clinical trial that was testing the efficacy and toxicity of epcoritamab, single track in patients with relapsed refractory aggressive B-cell lymphoma. And here you can see the patients that achieved a complete remission. Complete remissions are sustained over time. And for these patients, in 24 months, 60% of them were still in complete remission, and a little bit more than 50% of them at 30 months. So when we have a look at the new treatment algorithm for relapsed refractory diffuse large B-cell lymphoma, and this is a graph that has been taken from a paper published back in 2022 by Jason Westin and Laurie Sen. Unfortunately, we don't see the word allogeneic stem cell transplantation at all in this graph. And of course, I'm not going to discuss here, because this is not the topic, how CAR T cells have moved in second-line therapy and are kind of competing with autologous stem cell transplantation in patients with primary refractory or with early relapse. So how allogeneic stem cell transplantation is performing versus CAR T nowadays? This is a retrospective analysis coming from the Spanish Transplant and Cellular Therapy Group that was published in BMT 2023, including 316 patients, 101 patients being treated with an allo, 215 with CAR Ts from 2016 to 2021. All these patients failed at least 2 prior lines of therapy, and as you may expect, the median follow-up was significantly longer in those patients being treated with allo. And of course, some clinical characteristics before the procedure were also significantly different between both groups of patients. So as you can see, CAR T cells are associated with a higher relapse incidence, but allo transplant with a higher non-relapse mortality, and this makes non-significant differences in terms of progression-free survival and overall survival between both strategies. Similar results have been seen in a bigger retrospective analysis that has been performed on behalf of the Go-CART Coalition and presented by Bertrand Glass in a group of more than 500 patients that have been taken from the EBMT registry, where CAR Ts have been compared with allogeneic stem cell transplant as a third line of treatment strategy of more. So looking at the 515 patients that had complete information with respect to IPI, you can see a similar pattern. So non-relapse mortality is higher with allo, relapse incidence is higher with CAR T cells, and this represents non-significant differences in terms of progression-free survival, although overall survival is better with CAR T. And we can eventually try to segregate different subgroups of patients. So here we are looking at PFS and overall survival between allo and CAR-Ts in those patients with low and low intermediate IPI on the left-hand side of the slide versus those patients with high and high intermediate IPI. It seems that allo transplant, which are the blue curves, might be more beneficial in those patients that have high and high intermediate IPI. And a similar picture can be seen when we separate those patients with normal LDH levels at the time of the procedure, where CAR T cells seem to be given better long-term outcomes than allogeneic stem cell transplant. And we see a kind of different curves for those patients with more aggressive disease that have high levels of LDH at the time of starting therapy. So which might be the potential role of allo nowadays for patients with relapsed refractory diffuse large B-cell lymphoma? We have to take into consideration that CAR T cells are curative, but CAR T cells are not curing 100% of the patients, and we have more than 50% of the patients failing this procedure. And we know that the long-term outcome of these patients is quite poor. Here you can see a retrospective analysis published by Gloria Jacoponi only a few months ago, indicating that the median overall survival after CAR T-cell progression is around 5 months. And we only have 30% of the patients that are alive 1 year after disease progression. So allotransplant might be an interesting strategy, at least for some of these patients. This is the biggest retrospective analysis looking at the role of allogeneic stem cell transplantation in patients with relapsed refractory large B-cell lymphoma that relapse after CAR T. 94 patients were collected. As you can see here, 1 year overall survival and PFS were 59% and 45% respectively, with what it seems a plateau. GRFS is around 30%, and of course we have to expect high non-relapse mortality, 1 year non-relapse mortality of 22%, and 1 year relapse rate of 33%. If we look at potential prognostic factors in the multivariate analysis, complete remission at the time of allo, as one might have expected, makes a difference in both progression-free survival and overall survival, and also having received less than 2 lines of therapy between CAR-Ts and allogeneic stem cell transplant. And if we go back to the paper that I have already mentioned by Gloria Jacoboni, so there was a small group of 32 patients that were consolidated with an allotransplant. We have to acknowledge that it's a retrospective analysis. The follow-up is quite short, the number of patients is quite small, and they represent quite an heterogeneous population of patients with different bridging strategies, as you have seen here. But the median overall survival had not been reached, and we have an overall survival higher than 80% 1 month after the allogeneic stem cell transplant. So probably this is the subgroup of patients where allotransplant would eventually be considered. So let's move to mantle cell lymphoma. And if we go back to the exercise, looking at the data coming from EBMT, here we have seen a decline of more than 70% in the number of allos being performed over time, from 2010 to 2022. We have been doing allogeneic stem cell transplantation for many years in patients with relapsed refractory disease. We have to acknowledge that it's a curative treatment strategy that may give an overall survival between 25 and 40%, but of course it's also associated to a significant non-relapse mortality, which can be as high as 40% in some of the retrospective analyses that have already been published. The landscape in mantle cell lymphoma in this specific setting significantly changed with the data coming from SUMA-2, which is the phase 2 pivotal trial, including a little bit more than 60 patients with relapsed refractory mantle cell lymphoma that were treated with Brexucel. And we have nowadays the 3 years follow-up of these patients included in this trial. So the median progression-free survival for the global population of patients, as you can see here in this slide, is 25.8 months. better results in the blue line that basically represents those patients that achieved a complete remission with a median PFS of 48 months. And CAR T cells have nowadays been considered the standard of care in this population of patients. Although I want to acknowledge that we have some late relapses, as you can see here in this progression-free survival curve, where we don't see a plateau. So I think that we still need to better understand the curative capacity of Brexucel in these type of patients. We have data coming from real world, and these are data coming from the US Lymphoma CAR-T Consortium that analyzed 189 patients that underwent leukapheresis because of a relapsed refractory mantle cell lymphoma. 168 patients ended up receiving the drug, and in spite of the fact that almost 80% of them would have not met the SUMA-2 eligibility criteria, and that bridging was used in almost 70% of the patients, the complete remission rate was very high, 82%, with a 12-month PFS and overall survival of 59 and 75% respectively. So really very interesting results. Once again, how CAR T cells or how allogeneic stem cell transplantation is being positioned in front of CAR Ts in 2024. This is a retrospective analysis that is about to be published by the Lymphoma Working Party of the EBMT in conjunction with Gilead Kite. And the objective was to compare those patients with mantle cell lymphoma that had been treated with Brexu in the context of ZUMA-2 with patients that had been treated with an allogeneic stem cell transplantation and that had been reported to the EBMT registry. A propensity score matching strategy was used to homogenize both population of patients in terms of some clinical data. And the primary endpoint was 1 year overall survival. So the median follow-up was almost 3 years, and it was quite similar in both groups of patients, 36.5 months in ZUMA-2, 34.1 months in the allogeneic stem cell transplantation group. And as you can see here in this slide, this retrospective analysis was positive. The 1 year overall survival was significantly better for those patients being treated with Brexu, 81.3% versus allotransplant, 59.2%. But when we have a look at progression-free survival, as you can see here in this slide, progression-free survival is quite similar between CAR-T and allogeneic stem cell transplantation. And this is due to some non-significant differences in terms of non-relapse mortality and relapse incidence in a similar pattern to what we have seen with with diffuse large B-cell lymphoma, although here we approach the problem with a propensity score matching. So non-relapse mortality is higher with allotransplant. Relapse incidence is higher with the use of Brexucel, although none of these differences were statistically significant. And finally, if we have a look at the treatment-related deaths, as one might expect, progressive disease is the most frequent reason of treatment-related death for the CAR T-cell treated patients, while treatment-related issues, non-relapse mortality, is the most frequent treatment-related death in those patients that were treated with an allo. So with the advent of Brexucel, the NCCN guidelines were changed, and nowadays allogeneic stem cell transplantation is eventually considered in some fractions of patients that have eventually relapsed after CAR T-cell therapy. So let's go to follicular lymphoma. And in follicular lymphoma, we have a similar pattern. If we look at the EBMT numbers, we have seen a decrease of more than 60% in the number of patients that are being taken into an allogeneic stem cell transplantation. So allotransplant is a curative treatment strategy for relapsed refractory follicular lymphoma. And we have quite a lot of retrospective analysis that indicate that and that demonstrate that PFS and overall survival curves have a plateau. So here you have the PFS and the overall survival curves of probably the biggest retrospective analysis that was a joint study between EBMT and CIBMTR, including more than 2,000 patients. So PFS was almost 60% in both groups. Overall survival at 3 years was higher than 60%. But of course, allotransplant is associated with non-relapse mortality. And of course, nowadays we are seeing really very rich, interesting targeted therapy scenario, which is associated to less non-relapse mortality. And we have to talk about new drugs, about PI3 kinase inhibitors, antibodies, antibody drug conjugates, but basically about bispecific monoclonal antibodies and CAR T cells that for sure have represented at least in part or are the responsibles at least in part of this decrease. So here you have the 36 months follow-up of the pivotal trial that has given the indication to MOSU in patients with relapsed refractory follicular lymphoma. So the median PFS is at 24 months in the 90 patients that were included in the study, with a median overall survival that has not been reached. So this is a very competitive and effective strategy. And of course, we also have to discuss here autologous anti-CD19 CAR T cell constructs. So we have data coming from SUMA-5 regarding Axi-cell, coming from the ELARA trial regarding Tisa-cell, and also coming from some arms of the Transform trial looking at Liso-cell in patients with relapsed refractory follicular lymphoma. Here you have the data on the follow-up at 4 years of patients included in SUMA-5 with really excellent and very interesting results in terms of duration of response, time to next treatment, progression-free, and overall survival. And here you have the 3 years follow-up of patients included in the ELARA trial, specifically looking at the impact of POD24 status in terms of PFS and overall survival. Even the PFS curves are lower in those patients that are POD24 positive. The results are really very good if we try to compare them with more historical strategies. And one might think that 4 years or 3 years follow-up, probably it's not an enough long follow-up for patients with follicular lymphoma, but the reality is that we are getting there. So to try to give you some conclusion regarding the questions that we had at the beginning of the presentation, allotransplant in B-cell lymphomas in 2024, I would say that yes, but of course it depends on the histology and we have to look at a specific subgroup of patients. I would eventually consider, if we have the possibility to have CAR T cells and biospecifics, relapses after CAR T in patients with diffuse large B-cell lymphoma in some very selected subgroup of patients. It's really very difficult to find candidates when we talk about follicular lymphoma. What about mantle cell lymphoma? CAR T cell is the preferred cellular therapy treatment option, but we may consider allotransplant in selected patients if partial remission or complete remission is achieved. So that's the end of my presentation. I want to thank you very much for your attention. Happy to take some questions. And of course, I would like to invite all of you to come to the 51st annual meeting of the EBMT that will be taking place in Florence, end of March, beginning of April 2025. Thank you very much.
Thank you, Dr. Soga, for this comprehensive presentation about the role of allogeneic stem cell transplant in lymphoma. Now we can take the questions for the two speakers. Any question?
Thank you very much, Dr. Anna. So my question is, now we've seen that there is some hope for allogeneic transplant in DLBCL, for example. So how we can improve on this? Is there any role for maintenance therapy post allogeneic transplant just to improve on the outcome that's produced by this procedure?
So thank you very much for the question. Are you talking about diffuse large B-cell lymphoma? Because I am not.
Yes.
Okay. So, I mean, it would be interesting to check the role of maintenance therapy after allotransplant. I have to say that we don't have really strong data on the potential role of any maintenance therapy. We are not doing that in our clinical practice in the only few patients that we are still allografting in this specific disease. And we don't have prospective clinical trials looking at that, at least that I know of. So I don't think that we have to think about the role of maintenance therapy after allotransplant in this specific setting. It would be nice because, of course, we are still, I mean, we are facing a high relapse rate, but I don't think that we have data to support this strategy.
Any more questions?
So
I have a question for Raphael. We have noticed that some patients with who's getting herpes zoster vaccine, they develop herpes zoster, herpes zoster. I wonder what is the time between stopping acyclovir and the vaccination?
That's one of the tricks of the trade that we don't know. As you know, the recommendation for the vaccine does not contemplate or mention anything about prophylaxis. We normally do prophylaxis for at least 12 months. That's the standard recommendation after transplantation, and it has to be defined. The main point I wanted to highlight is that in reality, if we want to do the vaccine, and very early on vaccine, because it's the first 3 months, as you know, then it wouldn't really be very efficient as a strategy to do the vaccine and then continue with prophylaxis just the same way, because prophylaxis itself without the vaccine is already quite useful. So I think that's something that we'll need more experience for. There's a number of studies showing lack of immunogenicity in allogeneic transplant recipients primarily. There's very few small studies like our own showing hands-on experience as we start vaccinating patients, and I think that we just need a more clear study that defines this timing of discontinuation of acyclovir and whether or not there's a real benefit in allogeneic transplant recipients, because the studies were never done in allogeneic transplant recipients. They were done in autologous transplant recipients. We were very proactive recruiting for that. We participated in those, but not in allogeneic, and that's data that we need to have. Otherwise, it's just very speculative.
Thank you. Any more questions?
So the last question for Anna. Patient with diffuse large B-cell lymphoma who achieve remission by specific agent, would you recommend to do allotransplant after bispecific agent or not?
So that's another very good question that I don't think that has a clear answer. I have to admit that, well, first of all, bispecifics still have to demonstrate the curative capacity in patients with relapsed refractory diffuse large B-cell lymphoma. So, I mean, taking this into consideration, of course, it is quite tempting to try to consolidate these patients if they achieve complete remission with an allogeneic stem cell transplant, that we know that it's a curative treatment strategy. Of course, if the patient is an allotransplant candidate, the patient has a good donor, and there are no significant comorbidities. As time goes by, the reality is that we are gaining more experience on the capacity to keep these complete remissions over time in those patients that have achieved a complete remission. And I think that it's less and less clear, while taking into consideration that the evidence that we have with this consolidation strategy is really very small, and it only comes from a small number of patients in a retrospective fashion. I mean, it's not so clear that we need to risk a patient that is in complete remission with a bispecific with the non-relapse mortality, which is associated to allotransplant, that, by the way, does not seem to be significantly modified with the use of bispecific, at least short courses before allogeneic stem cell transplant. So in our clinical practice, if we face this issue, first of all, we have a lot of discussions within the team because nobody is in full agreement. Second, probably we would defer allogeneic stem cell transplantation in those patients that achieve a complete remission to give the patient the chance to have a continuous complete remission over time with a less toxic and very effective treatment strategy. It will be discussed case by case because there are no general guidelines. Of course, in those patients that do not achieve a complete remission, that are able to respond and have a significant response with biospecifics, we would consider allogeneic stem cell transplant to put them in complete remission and to try to cure the disease.
Thank you. Thank you for all the speakers for this review and answering the questions. We'll go to the next session.
Thank you very much.
Thank you.
Thank you.
So we'll go to the next session. It will be the SSI symposium. We're welcome back to David Louis,
who is a consultant hematologist with extensive experience in managing lymphoma. He is a principal investigator for multiple trials, and he will get to talk about practical consideration in the management of diffuse large B-cell lymphoma. David Louis.
So thank you once again for the very kind introduction, and it's really good to be standing in front of you again today. Hopefully you can hear me. I was trying to speak close to the microphone. So yeah, I'm David Lewis from Plymouth, and I'm going to talk you through practical considerations and management strategies of bispecific antibodies in particular. I'm sure you remember yesterday I spoke to you about bispecific antibodies and the current evidence for their efficacy. So we mainly focused yesterday on the efficacy and a little bit on toxicity profile of biospecifics. Today, really, we're going to focus more on the adverse event profile in a bit more detail that you see with bispecific antibodies and how you might take steps to mitigate them and also how you manage them. And I'm sure a lot of people in this room are familiar with these already, given that you work at CAR T centres and have got quite a lot of experience in treating patients with some bispecific antibodies. So there will hopefully be, here's disclaimer and disclosures. There will be some time for questions today because this is a slightly shorter talk than yesterday, so I'm very happy to take questions at the end and talk through things in more detail. But here's what I'm going to focus on. I'm going to talk first of all about cytokine release syndrome and ICANS. I'm going to talk through how we define those entities and how we might manage them and when you might want to jump in and treat them. And then we're going to talk about mitigation strategies. So all the bispecific antibodies that are available currently have different strategies to mitigate the risk of cytokine release syndrome, and I'll talk you through those in some details, particularly focused on the epcoritamab data. And then talking about how you might set up strategies by which you can identify CRS and ICANS quickly. Okay, so by way of introduction, let's just, and I'm sure that a lot of you in this room are familiar with this, but I'm just going to talk briefly through what CRS and ICANS are before we go into them in more detail. So cytokine release syndrome is an immunological phenomenon associated with T-cell engaging or T-cell activating agents that is characterized by sort of hyper-inflammatory type physiological process. It universally includes fever, so you can't diagnose a patient with cytokine release syndrome if they're not febrile. And in its later stages includes symptoms such as hypotension, hypoxia, and organ dysfunction. ICANS is an immune cellular associated neurological syndrome, which is associated by various symptoms, including dysphagia, dysgraphia, and aphasia, as well as in more severe cases, seizures and loss of consciousness. And again, I'm going to talk you through that in more detail on later slides. First of all, classification for cytokine release syndrome. I mean, as I said to you yesterday, I work in a centre that, whilst we do a lot of clinical trials, actually certainly when we opened the bispecific antibody studies, we weren't a CAR T centre. So in my centre, we had actually no experience of treating cytokine release syndrome at the time we opened the epcoritamab study and also subsequent bispecific studies. And we were, I would say, slightly nervous actually about dealing with cytokine release syndrome in our hospital, as I'm sure a lot of centres will be when they start giving these agents. By way of reassurance, I thought I'd just talk you through this. I mean, and again, you will have seen this before, but actually the grading of cytokine release syndrome is actually very straightforward and very easy to remember. And it's this is the ASTC to consensus criteria, which is used both for bispecific antibodies and for CAR T cell therapy. So for grade 1 CRS, you're talking about someone who's basically just got a temperature but otherwise well. So by definition, as I said, you have to have a temperature above 38 for CRS. So grade 1 CRS is temperature above 38 but no other symptoms. Grade 2 CRS is where patients are starting to, as well as having the fever, starting to drop their blood pressure a little bit or require some low flow oxygen. So grade 2 CRS is the sort of patient who might be febrile and look a bit like they've got a mild septic infection, but they're still well enough to stay on the ward. Grade 3 CRS and above is where you're really having to get maybe your help from your intensive care or HCU colleagues, because the grade 3 CRS is where patients are starting to require a need for high flow oxygen and possibly need inotropic support to support their blood pressure. And grade 4 CRS are these patients that we really worry about. These are the patients who need often quite intensive ITU support with multiple vasopressor support, or in some cases even requiring intubation. So in terms of CRS, grade 1 and grade 2 you can look after very happily on your ward. Arguably grade 1 CRS you could manage as an outpatient. Grade 3 and 4 CRS is really where you're needing the more intensive support. And similarly, the ICE score is used to assess the ICANS scoring system. And for those of you who aren't familiar with the ICE score, it's actually very, very straightforward and takes less than 2 minutes to do. The scoring is written at the bottom here, and you can just go through it with your patient, or a nurse on the ward can go through it with the patient in less than a couple of minutes. It's simply asking patients if they know where they are, if they can name 3 objects and follow commands, count backwards from 110s and write a standard sentence. And we found it very useful to establish what the patient's handwriting was like at baseline, because certainly I would almost certainly fail an ICE score with my handwriting on a good day. So I think it is important to establish a baseline for what your patient's handwriting looks like before you start the treatment, so you can actually pick up early if they're starting to get handwriting problems, because that tends to be one of the first things that goes when patients get ICANS. And the scoring system's written here, so the grading of ICANS is based on the ICE score, but actually you can get higher grade ICANS automatically if you're starting to drop your conscious level, and particularly if you get something like a seizure, that automatically gives you at least a grade 3 ICANS. Okay, so cytokine release syndrome really came to the forefront of everyone's minds because of the high rates that we see of cytokine release syndrome with CAR T cell therapy. And I think the advent of CAR T cell therapy into standard of care in diffuse large B-cell lymphoma has really focused people's minds on these sort of toxicities. And you can see that with the currently available CAR T products, you see cytokine release syndrome in the vast majority of patients who get axi-cell, and similar high rates, although lower with liso-cell and T-cell. It's really, I think, the things that everyone worries about with cytokine release syndrome are these grade 3 or 4 events, and these are the patients that need intensive care support. So you can see with axi-cell, you're sending, in some studies actually up to about 20% of patients to ITU for support. You can see that in terms of when it starts, it tends to start a few days after the CAR T-cell product, and it can take some time to resolve, up to a week for CRS resolution with the CAR T-cell product. So it was for this reason that everyone was slightly anxious about doing bispecific studies, because we were all concerned that we were going to see similar patterns when we opened our bispecific studies. But actually, our experience, and in fact the experience from the data reported, is that whilst you do see cytokine release syndrome with bispecific antibodies, there are two things that differentiate this from the CRS that you see with CAR T cells. First of all, although you see it in about 50% of patients across all the different studies that are available, you only see the grade 3 or 4 events in a very small proportion of patients. So you're only needing to involve ITU in a single-figure percentage of your patients on bispecific antibodies. And in fact, with the epcoritamab study, there were no grade 4 CRS events in the entire study of over 100 patients. The second thing about CRS, which is different from CAR T cells, is the time of onset tends to be very quick and predictable. It tends to be usually within a day of the first full dose of the bispecific antibodies. Now, the exact time of that first full dose does vary slightly from product to product. With epcoritamab, that first full dose is on cycle 1, day 15, and as we'll see in a minute, that is the most common time point for the development of CRS. So it's usually low grade, it's usually predictable in terms of time of onset, and the other thing is it tends to resolve quickly. So whilst you see cytokine release syndrome with bispecific antibodies, it's usually lower grade and has a predictable time of onset quickly after the first full dose with bispecific dosing. So there's the epcoritamab data, and again, just to highlight this in more detail, cytokine release syndrome in the GENO-1 study, which is the epcoritamab study I spoke through yesterday, is usually low grade and predictable, and the vast majority of CRS events occur following the first full dose. And this slide that I showed you yesterday illustrates that. So as I'm sure you remember from the epcoritamab dosing schedule, the first full dose is on cycle 1, day 15, and if patients get CRS, this is by far the most common time point to get it. And actually, but even though they get CRS, about 50% of patients do get CRS, it is usually grade 1 or grade 2. Fewer than 3% of patients had a grade 3 event. And of those patients that did have a grade 3 event, usually what that entailed was a 1 to 2 day trip for some inotropic support on ITU, and then they got better. Only one patient in the epcoritamab study actually discontinued epcoritamab because of CRS. Moving on now to ICANS. Actually, I would say most people who treat with CAR Ts, I think people tend to be more worried about ICANS than they are about CRS. And I think ICANS, of the two toxicities that we see with CAR T products, is the more difficult to treat. But certainly we are seeing significant rates of ICANS with all three currently available CAR T products. And the key thing here is those patients who had grade 3 or above ICANS, because these are the patients who get really sick and need ITU support. And actually there is a significant morbidity and mortality associated with grade 3 and above ICANS. It tends to be slightly unpredictable in terms of onset. It tends to happen in between 1 and 2 weeks after the CAR T cell infusion, and it often happens in patients who've had prior cytokine release syndrome. And you can see it can be quite challenging to manage, with time to resolution of symptoms being 1 to 2 weeks. So these are patients who are going to be sick. They're going to be needing to be inpatients nearly all the time, and as you can see, a proportion of these patients, a significant proportion of these patients actually need intensive care support, which leads to significant morbidity and in some cases, unfortunately, mortality in these patients. And again, we were very concerned when we opened our bispecific studies that we were going to see ICANS in our patients, so we were monitoring very closely for it. But actually, the other thing, just to caveat this data very slightly, I do feel that there's a trend, not just with epcoritamab, but across all of the bispecific studies, that ICANS could potentially be slightly over-reported in these studies. We were treating a largely elderly group of patients, and they had a lot of steroids as part of their ICANS CRS prophylaxis, which we'll come to in a minute. And actually, if patients had symptoms of ICANS, including confusion, you can probably imagine if you've got an 80-year-old patient that you're giving big doses of steroids to, some of those patients are going to get confused. So Martin Hutchings in particular, I know, is slightly cynical about whether these patients genuinely had ICANS. But what I'm showing you here is the reported rates of ICANS across the bispecific studies. And you can see that ICANS has been reported in all three. It's odronextamab, I haven't mentioned, by the way, is the Regeneron CD3, CD20 bispecific antibody. We didn't talk about that in detail yesterday. But ICANS, even when it was reported, is primarily low grade, so grade 1 to 2, and almost always resolved in all three of the currently available bispecific antibody therapy. So I would say with bispecific antibodies, whilst ICANS is something to be aware of, it isn't something that happens frequently. It tends to be very low grade and manageable with conservative management on the ward. Very rarely does it lead to treatment discontinuation. And concern about ICANS, although it's something that you have to consent your patients for and mention to them, it wouldn't be something that would prevent me or worry me about giving a bispecific antibody to a patient. You can see that, again, if it does occur, it happens relatively quickly after that first full dose and tends to resolve quite quickly. So ICANS has been reported in bispecific studies, but at very low rates, and it's very rare to be greater than grade 1 or 2. All of the bispecific antibodies have mitigation strategies in place in order to reduce the risk of particularly cytokine release syndrome. They're product-specific and disease-specific, so the different bispecific antibodies do have slightly different dose ramp-ups depending on the disease. For epcoritamab, the mitigation strategy is, first of all, steroid prophylaxis. And for those of you in the room who haven't seen the dose optimization data that was presented at ASH, I would strongly recommend using dexamethasone as your steroid prophylaxis in bispecific antibodies, as this does seem to significantly reduce the rate of cytokine release syndrome. With epcoritamab, you start with a small dose of 0.16 milligrams on day 1, followed by intermediate dose on day 8, and the first full dose of 48 milligrams on cycle 1, day 15. With epcoritamab, we routinely use steroids. As I said, I would recommend dexamethasone for that, and we tend to use steroids in that first cycle, in other words, the first 4 doses. If patients don't have cytokine release syndrome, you can then stop the steroids. You do have the option of continuing giving steroid prophylaxis if patients do have some cytokine release syndrome. Glofitamab uses obinutuzumab on cycle 1, day 1 as its CRS mitigation strategy. And we always pre-med our patients with antihistamines and antipyretics. And it's important to adequately hydrate patients. In terms of monitoring for cytokine release syndrome, as I showed you on earlier slides, if patients do get CRS, it's highly predictable in terms of the timing. And so we recommend, and in fact the licensing recommends for epcoritamab, that on that first full dose, that patients do have a period of observation, and we tend to admit our patients onto the ward for observation. If you have a patient you're particularly worried about cytokine release syndrome, for example, if you're treating a 90-year-old patient who may have comorbidities and, for example, maybe some renal impairment or something like that, you might want to admit them earlier and monitor them on the cycle 1, day 1, just because you might have a lower threshold for going with tocilizumab, but that's very patient-specific. But certainly, cycle 1, day 15 is where it's recommended to admit and monitor the patients for 24 hours. And similarly, glofitamab has a similar recommendation to admit on that first full dose. CRS management, I've got some more slides on CRS management coming up, but basically, and I'd be interested to hear what your practice is, but my practice actually is, when I started doing these bispecific studies, I only really wanted to go in with tocilizumab when people were almost on the cusp of a grade 3 CRS event, because I was worried that it might impact the efficacy. But as we've got more confident with these agents, I'm going in early with tocilizumab, and I would certainly tend to go in with tocilizumab for a grade 2 event. I have even given tocilizumab for grade 1 CRS before for very elderly patients with comorbidities. But certainly, I think across the board, dexamethasone consider, although bear in mind that if patients get CRS, it's likely to be in that first cycle, so patients will have already had steroids as part of their prophylaxis. So I would only tend to I would keep the steroids in my back pocket, and actually I would go in early with tocilizumab for grade 1 and grade 2 CRS. Grade 3 CRS, you're definitely going to give tocilizumab. You might want to repeat the dose later on in the day. I've never seen a grade 4 CRS event with a bispecific antibody, but if those patients you will need ITU admission, they will have tocilizumab, and you may consider alternative agents if they're not responding to tocilizumab. ICANS, as I said, primarily low grade with bispecific antibodies, and I would say the management is largely supportive for these patients, with a consideration for dexamethasone for grade 1 and 2, but again, bearing in mind that they will have already had steroids as part of their prophylaxis, particularly with epcoritamab. So this is just a reminder of cytokine release syndrome in more detail. This is from slides that we produced in the UK for our bispecific program. So again, for grade 1 CRS, you can consider tocilizumab in patients. So these are patients who've got a fever but are otherwise well. I have to say I have occasionally treated patients with tocilizumab with a simple grade 1 CRS. As I said, I've treated a 90-year-old patient with EPCO before. If you're at all concerned that the patient may become unwell, there's absolutely nothing wrong with going in with a dose of tocilizumab if you're worried about your patient for some reason. And usually, in my experience, if you give a single dose of tocilizumab, the fever resolves very quickly. In case of concurrent ICANS, consider steroids, although, as I said, bear in mind that patients will have already had steroids if they're getting it in that cycle 1. And importantly, hold epcoritamab until the resolution of the CRS event. Although actually, as I've shown you, most of these CRS events do resolve quickly, especially if you give tocilizumab. So actually treatment delays because of CRS with bispecific antibodies are actually quite rare. And do remember your supportive management and make sure patients are well hydrated. By the time you get into grade 2 CRS, when people are actually dropping their blood pressure or needing some oxygen, I have a very low threshold at that stage to go into tocilizumab, and the vast majority of patients will get better very quickly with 1 dose of tocilizumab. If your patient has a cytopenia or is at risk of infection, you might want to consider treating for sepsis as well in some patients. But if a patient gets a fever on that cycle 1 day 15 time point, the most common cause is going to be CRS. So I would consider infection and treat it if you think you need to, but I think the tocilizumab is the mainstay of treatment. Grade 3 is where patients are requiring a bit more oxygen and are needing potentially inotropic support. I've treated over 30 patients now with epcoritamab. I've yet to see a grade 3 event actually. So perhaps I've just been lucky, but the study suggests that grade 3 events are only happen in about 2.7% of patients. If your patient is unfortunate enough to need intensive care support, then definitely you're going to be giving a tocilizumab at that stage. You might want to repeat the tocilizumab. Remember, maximum of 2 doses in 24 hours. And you might want to consider alternative anti-cytokine therapy if CRS is refractory. I would personally, if patients are that unwell, be considering alternative diagnoses as well, such as sepsis, because as I said, grade 3 CRS is actually quite rare, and so I do think it's important to consider that this may not actually be CRS and consider treating with antibiotics, etc. Steroids, again, you can give more steroids than they've had in prophylaxis, and these are the sort of patients where you may want to give more steroids, particularly if they've got concurrent ICANS, and importantly, hold EPCO until it's resolved. You can redose with EPCO if patients have had a grade 3 CRS event, but what you should do is, if patients get a grade 3 event more than 72 hours, or if they get 2 grade 3 CRS events, then you have to permanently discontinue epcoritamab. And similarly, grade 4, which has not yet fortunately been reported in the initial phase 1/2 study, those patients should have permanent discontinuation of epcoritamab if they have a genuine grade 4 event. And again, you may well be considering alternative anti-cytokine treatments in these patients, and definitely you should consider alternative courses, bearing in mind these patients will be severely immunosuppressed by the time they get to bispecific antibody therapy and may be at risk of atypical infection. So I would have a very wide differential diagnosis for these patients and consider looking very hard for other causes. So infections, I got asked yesterday what I tend to do with infection management for epcoritamab. I treat these patients as if they're immunosuppressed. By definition, these are patients who've had 2 prior lines of treatment, and they are going to be lymphodepleted. As well as this, bispecific antibodies are B-cell depleting agents and may potentially cause T-cell exhaustion as well. So I give every patient that I'm giving a bispecific antibody acyclovir and cotrimoxazole prophylaxis, and I would monitor them closely for atypical infections if they get fevers, and definitely need to withhold epcoritamab until infection is resolved. If patients get febrile neutropenia, you should treat them as per local policies and withhold epcoritamab until neutrophils are above 0.5. I do give GCSF support, particularly in that first cycle if patients are getting neutropenia, because I think it's important to try and get the treatment in if you can. So to conclude this sort of talk on practicalities, EPCO is given weekly, cycles 1 to 3, fortnightly 4 to 9, and monthly from cycle 10 onwards. We can mitigate the CRS risk with step-up dosing and pre-medication, including steroid for CRS prophylaxis. You should monitor signs for patients with signs and symptoms of CRS and ICANS following that first full dose on cycle 1, day 15. Although, bear in mind, most of these events, if they do happen at grade 1 or grade 2. And there are, I'm just mentioning at the end that there are recommendations on repriming for epcoritamab for what you actually do if you have dosing delays. And that depends slightly on where you are in the dosing schedule, but there are very clear repriming recommendations as to when you need to reprime your patients and what you do depending on dose delays. So just talking about this patient I presented yesterday, I've got a couple of minutes left, haven't I? More or less? Yeah. And then we'll have some time for discussion. So this is this 75-year-old patient I spoke about yesterday who had stage 4 disease, went on to have first-line treatment with R-polar chip. He had a partial response, but then had progressive disease after 6 cycles. He then went on to receive second-line GemOx, as he wasn't felt to be an autologous stem cell transplant candidate, which meant that he wasn't eligible for second-line CAR T-cell therapy in the UK. He did have a partial response after 2 cycles, but then unfortunately progressed after cycle 4. As you can see from his PET scan, he's got very extensive disease, with a bulky disease with a high total tumour metabolic volume on the PET scan, and a very high proliferative disease as evidenced by his high LDH. And there is actually evidence that I'm sure you've seen that patients with high total tumour metabolic volume are actually slightly more at risk of symptoms like cytokine release syndrome. So these are the sort of patients where you may want to keep a slightly closer eye on them and have a lower threshold for going in with tocilizumab, because patients with bulky disease are more likely to get CRS. As I mentioned to you, he's also got some comorbidities, including renal impairment, a slightly reduced performance status, and a slightly borderline cardiac function, as well as psoriatic arthritis. And again, these are the sort of things that would make me think this is the sort of patient where actually I would be monitored and maybe slightly closer, and would have a lower threshold actually to go in with tocilizumab for even grade 1 CRS, because what you don't want to happen is you don't want that patient to lose what remaining renal function they have, and they're also going to be more this is the sort of patient that might be a bit more challenging to support on the intensive care unit because of their slightly impaired cardiac function. So this is exactly the sort of patient where I'd have a slightly lower threshold for treating CRS early and keeping a closer eye on them. So in terms of what option I would choose, we spoke about this yesterday, and we spoke, I'm sure you remember yesterday, about the fact that this is a patient who may well not get to CAR T-cell therapy, and actually has a poor performance status, so might well have significant toxicity with CAR T-cell therapy. And actually I would argue that a bispecific antibody is actually a very good option for these patients, as it's an off-the-shelf product with no lead-in time to actually manufacture it. So this patient did receive epcoritamab, and he developed a fever as predicted on cycle 1, day 15. He didn't have any evidence of hypotension, and he had normal oxygen saturation. So cycle 1, day 15, he's got a fever, but no cardiovascular or respiratory compromise. This is a grade 1 CRS by definition. I think it would be important to think slightly about other causes of fever, such as infection in this heavily pre-treated patient. But the most likely thing, given the timing of onset of the fever, is cytokine release syndrome. So this is a grade 1 cytokine release syndrome event, and as I said, consider anti-cytokine therapy in certain cases. So this patient's he's advanced age, 75, so I think we'd probably say yes. He's got a high tumour burden, and he's also got some comorbidities, which I would argue is actually a reason to go in early with cytokine release syndrome treatment. So this is the sort of patient where actually I would recommend going in early with tocilizumab. And although consider steroids in the case of ICANS, this patient didn't have evidence of ICANS, and this patient had already received prophylactic dexamethasone as part of their prophylaxis. So I didn't give extra dose of steroids for this patient. And you have to hold off the eccritamab until the CRS is resolved. So thank you very much for listening to me again, and I'm very happy to take any questions.
Thank you, David, for this comprehensive presentation. If there's any questions from the audience? So no more questions? No more questions, so we'll have break for 10 minutes. Then we'll
Thank you very much.
So it will be presented by Dr. Abdul as you all know, Dr. Abdul is a consultant in other central transplant in King Abdulaziz Medical City in Riyadh. He's also the chairman of Blood and Cancer Research Center in Kmart. His experience was also in the Washington Central, Missouri, USA. He will talk about the refractory AML challenges.
All right, Assalamu alaikum wa rahmatullah. Thank you very much for the nice introduction, and I would like to thank Astellas for giving me this opportunity to present this satellite symposium. I will talk about relapsed refractory AML, specifically about FLT3 AML. So nowadays we rely heavily on molecular profiling for diagnosis of acute myeloid leukemia, and this will help us actually to identify the right subclass of AML and identify the risk that is associated with this disease, and also will help us to choose the proper treatment, proper targeted therapy nowadays we have, and also as a tool for MRD monitoring. So AML is a heterogeneous disease. It's genetically defined disease, so we rely heavily in the genetic profiling of the AML to subclass the type of AML as well as risk stratifications. So genetic profiling is very important here in terms of risk stratification, so you can know what type of treatment that you want to start in upfront setting and also in relapse refractory setting. And before that, also what kind of consolidation you would consider for this patient based on their genetic profiling. As we know that FLT3 is one of the most common genetic mutation that we see in AML, constitute more than 30% of patients. Majority, they have the ITD mutation. Very few, less than 10%, they will have the TKD mutation. And as we know historically, FLT3 has been associated with poor outcome for patients treated with standard induction chemotherapy. Nowadays, we have multiple agents approved for treatment of FLT3 AML in different indications. We have two types of FLT3 inhibitor. We have the type 1 FLT3 inhibitors, which actually targeting both the ITD mutation and the TKD mutation. Example for that is midostaurin and gilteritinib. And we have type 2 mutation, type 2 inhibitors, which specifically targeting only FLT3 ITD. An example of that is sorafenib and gilteritinib. In the upfront setting, the RATIFY study led to the approval of midostaurin as the first ever targeted therapy for acute myeloid leukemia in upfront setting after this randomized study, which include patients who are FLT3 ITD positive and FLT3 TKD. This study showed a significant improvement in overall survival for those who received midostaurin in the induction and consolidation phase, followed by maintenance for those who did not go into transplant without randomization in between. And the median overall survival was 74 month versus 25 month midostaurin versus placebo. And what's remarkable here is if you look to the patient who went into allogenic transplant, while in CR1 they have a significant remarkable improvement in overall survival. Thinking about the role of utilizing the FLT3 inhibitor within the upfront setting during induction and consolidation, followed by stem cell transplant, knowing that maintenance midostaurin was not allowed in the post-transplant setting in this situation. So you can see that there is a remarkable overall survival curve here for patients who receive transplants in the upfront setting. Similarly, more recently, quizartinib, which is FLT3 specific, has been approved in the upfront setting based on the Quantum first trial. Again, newly diagnosed AML, but FLT3 only patient who received quizartinib in the induction, followed by and consolidation, as well as maintenance. And you can see that there was an improvement in overall survival. The median overall survival of 31.9 months for quizartinib versus 15.1 months for placebo. And again, patients who went into allogeneic transplant while in CR1, they actually have the best outcome for those who receive quizartinib in the maintenance as well. So what happened to those who relapse after upfront setting for FLT3? The outcome is dismal. Some of them they will still retaining the FLT3 positivity, and some of them they will have FLT3 negative relapse. And the pattern of resistance, or the kind of disease that relapse after the use of FLT3 inhibitor in the upfront has been evaluated based on multiple data. Specifically for those who receive type 2 inhibitor, which is specific for ITD, they usually relapse with the FLT3 TKD, and they have worse prognosis compared with those who do not. And for those who receive the type 1 inhibitor, for example, midostaurin, they will have mutation, or they acquire mutation in the RAS pathway, and they do have a worse outcome. So within the relapse refractory setting, I'm discussing here the QuANTUM-R study, which evaluated the quizartinib in the relapse refractory setting for a FLT3 ITD patient. They enroll patient age above 18, and then they should be a FLT3 ITD positive patient. And in this study was compared to salvage chemotherapy, which was MEC in 33% of patients, FLAG-IDA in 43% of patients, and 24% of patients they went into low-dose RSC. And the primary endpoint was overall survival in the intention to treat population. It showed an improvement in the median overall survival, meeting the primary endpoint with 6.2 months for quizartinib versus 4.7 months for salvage therapy. And this led to approval of this medication in Japan many years ago. Gilteritinib, as I said, is a type 2 inhibitor which targets type 1 inhibitor which targets both TKD and ITD, and has been evaluated in the Admiral study, which meant to investigate the benefit of gilteritinib in the relapse refractory setting, FLT3 ITD and TKD positive. And the patients were randomized to receive gilteritinib and salvage chemotherapy, and the primary endpoint was overall survival and response rate as well. So as you can see here, if you look to the patient characteristics, median age was around 62, and majority of them, they were intermediate, which is typical for FLT3 positive patient. And around only 12 or 13% of patients, they actually had FLT3 inhibitor prior exposure, and around 20% they were relapsed post transplant. Looking into the type of pre-selected salvage chemotherapy, around 60% of patients they were selected for intensive chemotherapy, which was balanced between both group. Majority of patients, of course, they have ITD mutation. The co-primary endpoint was the CR, and CRH was met with the gilteritinib showing 34% CR/CRH versus 15% for salvage therapy, and the CR rate was actually 20%, 21.1% in the gilteritinib versus 10% in the salvage arm. And the overall survival endpoint was met with the improvement in overall survival, showing that gilteritinib had 9.3 months versus salvage chemotherapy of that had 5.6 months. And looking to post hoc analysis, those who went into a transplant, they did actually better, thinking about this as a bridging way to go for allogenic transplant. Different subgroup showed similar benefit from the use of gilteritinib in this study. There was no significant safety concern when it comes to use of gilteritinib in the post and the relapse refractory setting. Again, the similar study was replicated in Asia. They call it the Commodore trial, having the similar patient population. phase 3 multicenter open label study, which showed again gilteritinib arm showing a median overall survival of 9 months versus 4.7 months for salvage chemotherapy. So this makes the gilteritinib as a standard of care for relapsed refractory FLT3 ITD patients. So thinking about the role of FLT3, so we talk about it in the upfront setting in the relapse refractory, and now we'll talk about it in the post-transplant setting and the role of maintenance. We should keep in mind whenever you think about maintenance in AML, this should have suppress the evolution of the residual leukemia, and this should not add a lot of toxicity for those sensitive patients, and also should have an ease on administration and reduce the frequency of monitoring, because if you think about giving prolonged maintenance therapy for 1 or 2 years and mandating the patient to come to the hospital and getting like subcuts injections or IV injection, this will be not feasible for patient with AML. And specifically for post-transplant setting, this should not increase the risk of graft versus host disease, should not affect the risk of graft versus leukemia as well, should not lead to any cytopenia, which is very important in that situation, and also should not interact with the post-transplant medication, including anti-infection prophylaxis and immunosuppressive medication. So there's a delicate matter here we should handle when we consider using maintenance therapy for patient post-transplant setting. So there are multiple randomized studies done in the post-transplant setting, and we will discuss some of them. So sorafenib maintenance was evaluated in a SORMAIN study, including a patient with FLT3 ITD. It's a phase 2 randomized study. It has relatively small number of patients, around 50, around 40, 45 in each arm. And they were randomized to use sorafenib versus placebo, knowing that not many of patients in this setting, they receive FLT3 inhibitor in the upfront setting. So majority of them, they are FLT3 naive. And also they include some patients with relapse refractory disease as well. So patients were randomized to receive sorafenib versus placebo, and you can see it's met its primary endpoint with a significant improvement in relapse-free survival, with a 2-year RFS of 85% for sorafenib versus 50% placebo, as well as overall survival improvement, trend toward overall survival improvement with a 2-year of OS of 90% versus 66%. There was no MRD data driven in this study. Subsequently, Chinese group, they published their experience with the use of sorafenib in a phase 3 open label randomized study, relatively higher patient, almost double the number from the previous study, using sorafenib versus control, because this was an open label study. And what we should highlight here, that majority of patients, they are younger population, which is not what we usually see with the FLT3, and also all patients universally they use myeloablative conditioning regimen, and less than 50% of patients, they were exposed into sorafenib. Around 27 or 30% of patients, they use sorafenib in upfront setting, and the rest, they actually use it in the relapse refractory setting. So again, homogeneous population, newly diagnosed, relapse refractory in this situation, indicating high-risk patient population. Still, we can see that the sorafenib led to much lower incidence of relapse, improvement in leukemia-free survival, as well as overall survival. Midostaurin was tested in the post-transplant setting, which did not show any improvement in the outcome. So this was a negative study. And more recently, the MORPH trial reported the use of gilteritinib in a post-transplant setting as a maintenance post-AML for FLT3 positive AML, including ITD patient only. And in this study, they randomized around 178 patients in each arm between gilteritinib and placebo. The study did not meet its primary endpoint, where the relapse-free survival, there was a trend toward improvement with gilteritinib, but that was not statistically significant, with a 2-year RFS of 77% in gilteritinib versus 69.9% in the placebo arm. And also there was no improvement in overall survival as well. And you can see Still, the placebo group, they did actually remarkably well, comparing them with the previous study. But what was interesting here that there was robust MRD data compared to the previous two studies. So robust MRD data using ultra-sensitive BCR NGS assay that detect at deeper level the residual FLT3, and this MRD data was maintained throughout the study. And what they found that there was actually benefit for those who were MRD negative. So looking into patients who were MRD negative pre-transplant and receive MRD positive pre-transplant and receive gilteritinib, they have improvement in relapse-free survival compared to those with placebo, while you can see MRD negative population in the right hand, there was no benefit of gilteritinib. So as I mentioned, this is just to show you the percent of patients they were analyzed. They have an MRD data around more than 90% of patients actually they do have an MRD data. In the pre-transplant setting, 46% were detectable in their MRD, and in the post-transplant, around 20% of patients they have MRD positivity. So overall, patient 50% they were MRD positive, and whether patient have MRD positivity pre or post-transplant, gilteritinib use was actually associated with better outcome. So in conclusion, FLT3 ITD has very low probability of achieving second CR in relapse setting. So novel agent is needed in this situation. Gilteritinib is the approved indication and the only approved indication in this situation in relapse refractory AML. And I think MRD assessment is very critical now to think about it, especially for patients go into allogeneic transplant to determine what kind of maintenance to be used in the post-transplant setting. With that, I conclude and happy to take any questions.
Thank you very much, Mr. Badr. Thank you for being on time, so we can have some time for questions. Anybody wants to ask questions? I might start with about your last study about the gilteritinib and post-transplant patients. They used it in mainly ITD patients. FLT3 ITD patients. There were issues about, like, sometimes gilteritinib is more with FLT3 ITD more than AKD or even other variants. But then, just because it's, at least it showed a bit of MRD improvement, but as you said, there is no statistically significant outcomes, especially after transplant. But they do continue them on the maintenance, or at least they keep them on gilteritinib. Or do you think they're going to do a longer study, or a longer time studies?
Yeah. So patient. This was the primary objective from this study is to test whether gilteritinib will improve outcome post-transplant. Is that what you mean? Yeah. So all patients they get post-transplant, if they are in CR, they were randomized to receive gilteritinib versus placebo. And as you can see, the primary endpoint was not met, but those who were MRD positive pre-randomization, they were actually they benefit actually from the use of gilteritinib in that specific setting.
Did they mention anything about, so especially post-transplant patients, cytopenias is a major issue?
Yeah, there were actually some signals and increase some toxicity associated with the gilteritinib, but I haven't reviewed the profile here for that. But overall, the non-relapse mortality was higher in the gilteritinib arm compared to the other, and opposed to what we see in the sorafenib study. But by the way, the JCO paper for the sorafenib study, there was actually numerical increase, and there are like doubling in the rate of graft-versus-host disease for patients who receive sorafenib. Yet the author in the paper did not. They consider this that as an equivalent, but if you look to the number, it's almost double the number of the GVHD, and this was a concern with the use of sorafenib in the post-transplant setting.
Yes, like I was going to talk about also this sort of skin reactions and the increase in GVHD, these things, but as you said, they didn't really mention much about them. Did they mention anything, or did you just?
Correct. Yeah. I mean, there is an increase toxicity associated with that, but maybe it wasn't statistically significant. But we know that from our experience, we'll use FLT3 inhibitor, regardless of that type of inhibitor. There is an increased risk of adverse event, adverse effect. So we should be able to be able to manage those and anticipate these complications. So they need close monitoring and early initiation of therapy if needed, and so on.
Other question? We have at least like 2 more minutes. Other comments? And do we still do, I mean, do we do MRD, the MRD testing that we do here in our institute? What I meant, like, do we try and test for it? Do we have like difficulties or?
Yeah, we don't have this assay available in our hospital, like the MRD for FLT3 ITD. It's not available. We have our own FLT3 BCR, which is not ultra sensitive as this, but we do FLT3 monitoring post transplant from time to time, just to inform us about the FLT3 status. But we don't have the MRD monitoring. But I think this is what's going to change in the future. Like the role of MRD in FLT3 is robust. There are multiple data about this outside this even study, and this is going to be probably in the future the standard of care.
Thank you very much.
All right, thank you very much.
We'll move on to some local experiences in stem cell transplant for colleagues. So the next talk is local experience from Oman, from Dr. Threya al-Husaydi. I welcome you to the stage. And Dr. Threya is actually a consultant hematologist at Sultan Qaboos University Hospital from Oman. She has had experience in Canada, Toronto, and British Columbia. She's going to talk about the local experiences of stem cell transplant.
Thank you so much for the kind introduction, and thank you for having me today to present my experience in hematopoietic stem cell transplant. So I will start my presentation with a brief introduction to Oman, just to get a sense of our demographics and how our healthcare system works. And then we'll move on to describe our allogeneic stem cell program at Sultan Qaboos University Hospital, and speak on the recent changes in our healthcare system as well. And we will present some data on our transplant program and its performance. and then eventually finish my presentation with some challenges and future directions. So the Sultanate of Oman is one of the Gulf countries with an estimated population of 5.3 million as of Friday, August 23rd, 2024. Our population growth estimated to be 2.5% per year, and we relatively have very young population, with majority of our population falling in the age category between 15 and 64 years. We have only 5% of population who are 50 years and above, and of course this has a major implication in terms of our transplant age and performance. The median age in Oman is 29.5 years. So the healthcare system of Oman is governed by the Ministry of Health. It is government-based healthcare system. We do have private sectors, but the Ministry of Health is a central governing body. We have Sultan Qaboos University Hospital as a leading center in hematology and bone marrow transplant. And we had some changes recently into our healthcare system, where University Medical City was introduced. And this change was basically to allow access between three main centers in the country, including Sultan Qaboos University Hospital, Sultan Qaboos Comprehensive Cancer Care and Research Center, where they treat solid tumors. And in 2023, the opening of National Omani Hematology and Bone Marrow Transplant Center as well moved some of hematology care to that center as well, which I'm going to talk about later in some more details. So the University Medical City now has under its umbrella three major centers, and again it is still governed by the Ministry of Health. This is Sultan Qaboos University Hospital for those who haven't visited Oman. It was established in 1986, and it is affiliated with the Sultan Qaboos University, the only public university in Oman. It has grown to become a leading medical center providing comprehensive healthcare services with a mission to deliver high quality patient care and promote health education and advanced medical research. The hospital has been dedicated to train healthcare professionals in different specialties since its start in 1986. And hematology department within the Sultan Qaboos University Hospital has been known as a national reference center for hematological disorders. We cater different disorders from non-malignant hematology to advanced hematological malignancy services between leukemias, lymphomas, myeloma. And of course, it holds the only transplant center in Oman for allogenic stem cell transplant at the moment. So the allogenic stem cell transplant program started in 1995. It started as a single bed HEPA filtered unit, and they performed 4 transplants in 1995, a very slow start. They expanded to include 2 beds within the unit, and we currently has 4 beds capacity as of 2024. The current operations of the program, so we have an estimated 25 to 28 allogenic pediatric and adult stem cell transplants performed per year. Our numbers have expanded in the last 5 years, so I'm going to show in a bit. The autologous stem cell transplant is done outside of the BMT unit, and it's usually performed in single rooms of pediatric and adult hematology wards. So our intake is mainly local transplants that are done at our local BMT unit. We take referrals for allogenic stem cell transplant from all over the Sultanate of Oman. However, I think it goes without saying, we are limited in terms of our numbers of beds with only 4 beds unit. We cannot offer transplant to our acute leukemias, especially in timely manner. And here where treatment abroad pathway comes, which is fully covered government referrals to get transplant abroad. And this has been actually a great help, offering timely manner facilitated transplant for urgent cases that cannot wait for a bed availability at our local unit. Once patients finish their transplants and come back to Oman, we resume their care. Usually they are sent back to Oman between day 40 plus or day 100 post-transplant, depending on the center that they received the allogenic stem cell transplant at. So as of February 2024, we have performed 719 transplants in total, 619 cases of allogeneic stem cell transplant. Those are the numbers performed locally, not to add any, not to confuse you with the treatment abroad pathway. These are all local transplants. We have performed 100 cases of autologous stem cell transplant at Sultan Qaboos University Hospital. And with respect to fractionation, as you can see, 81% of these are allogenic and 19% are autologous. This is the distribution as of 2017. Again, almost 80% allogenic, and auto accounts for 19 to 20% of all our cases. I have run more of data analysis just recently, just to see if our estimation and our fractionation are still the same. We are actually still at 81% of all cases allogenic and 19% autologous stem cell transplants. Our numbers have increased as the unit started in 1995. As I mentioned before, we have only 4 transplants performed that year, but we did have a growth year by year, approaching almost 52 transplants in 2022. So you can see that there is a steady increase in numbers between 2014 to 2022, and this all comes to how effective turnover between the beds and how effectively we are using our 4 beds unit. When it comes to donors, we are lucky that we have a huge pool of matched sibling donors. I mean, the majority are coming from matched sibling donors, which account for 83% of all transplants performed. 15% of our transplants are haploidentical, and we do at some occasions perform match-related donor transplants. With respect to indications, malignancies constitute the almost 50%, which is the half of our indications for transplant, i.e. acute leukemias. We do perform transplants for primary immunodeficiency, bone marrow failure disorders, which constituted 29% of our total transplants, and hemoglobinopathies constituted 23% of our total transplants. That being said, this data is a bit old, going back to 2017, and yet we have to do a new run analysis of our indications and see if these proportions are still holding. This is just a fraction again of our indications, where inherited disorders, being frequently transplanted along with hematological malignancies. Under non-malignant indications, we have transplanted variable diseases. As example is HLA class 2 deficiency, interferon gamma receptor deficiency, severe combined immunodeficiency syndrome, HLH, Fanconi's, Glanzmann thrombocythemia, and CGD as well. And I have again done some analysis on our cases in 2024. You can see the total number of AML cases were 114 so far. We have transplanted 90 cases of sickle cell disease patients locally and 83 thalassemia patients locally as well. The rest are just small numbers, but these are the highest numbers we have transplanted in our unit so far. I think when it comes to sickle cell and thalassemia experience, those are not small numbers for a population of 5 million, and I think it is worth getting more detailed analysis of these patients in terms of their outcomes, conditioning regimen, stem cell source, and share our experience when it comes to sickle cell disease and thalassemia specifically. As I mentioned, our population is relatively young, and it's not surprising that most of our transplants are between pediatric up to age of 40, and we have less patients getting allogeneic stem cell transplant at an older age. Just knowing our population is relatively young, and we have only 5% of patients who are 65 years and above. Stem cell source by far is peripheral stem cell, which is mostly the current practice right now. We are still going for bone marrow harvest when indicated, especially for bone marrow failure syndromes, aplastic anemias, thalassemia, for example, immunodeficiency. So that is still ongoing, especially among pediatric age group. We have recently looked at our acute leukemias, how they have done in the last 5 years, and our main question in this paper was basically to look at the impact of COVID-19 pandemic on our outcomes. But I was able to get our transplant data from this paper and just to show the rates of transplants for acute leukemias in the last 5 years. So in this paper that was recently published, we included patients who are diagnosed with acute leukemias, either AML or ALL, between January 2017 and December 2021. We identified 493 patients and included only 13 years and above. I don't know how it works here in Saudi Arabia, but in Oman, anyone who is 13 years and above is treated as an adult, and they are under adult care. So those patients who met the criteria newly diagnosed in this time frame were included in the study. We did exclude large number of patients, to say the least, and that's not surprising, knowing that some patients are being sent abroad for transplant, and we don't have information on their outcomes. So that led to some exclusion. We included 151 cases, and as expected for adult population, the AML by far is more common than ALL cases. And I mean, when you look at our numbers are not small. And this is just a single center experience. We are currently, based on the study, getting almost 100 cases of acute leukemias per year. And that's not a small number for a single center. When we go to the details about transplant rates, so before COVID-19 pandemic, i.e. before 2019, 39% of patients received allogeneic stem cell transplant for ALL. And after 2019, 30% received allogeneic stem cell transplant for ALL. When it comes to AML, the rates of transplant are higher, understandable, approaching 48% and 52%. So the rates of transplants remain the same. It's fair to say that our rate, when it comes to T-cell depletion, graft manipulation, busulfan, pharmacokinetics, everything is done locally. We also have in-house blood bank at Sultan Qaboos University Hospital, in addition to getting a direct access from Central Blood Bank in Oman as well, in cases of any shortage. TBI access was a challenge for us. So we did have TBI access through the Royal Hospital back in 2010 up to 2014. Unfortunately, that access was lost when the Medical Oncology Service moved to Sultan Qaboos Comprehensive Cancer Center. But we were able to reestablish that connection. In May 2023, we did the first adult patient with receiving myeloablative TBI in a 13-year-old female with mixed phenotype acute leukemia. We have recently done, I think just to commend their expertise, they have taken a patient with a BMI of 61 to receive TBI, and it went so smoothly without any limitations. And just a few weeks ago, we were able to do the first case of pediatrics receiving myeloablative conditioning as well, and that connection was established. This is a major milestone for us because prior to this, we were sending patients with ALL to receive allogeneic stem cell transplant abroad because of TBI access, even if we had a bed for them. So this is for sure is a game changer. We are accredited. We hold accreditation by Accreditation Canada International, and we are also a member of SSBMT. I think this is the highlight of my talk today, the National Omani Center for Hematology and Bone Marrow Transplant. It was opened in 2023. This is a dedicated hematology and bone marrow transplant center. We are currently operating at the outpatient setting, including daycare unit and specialized clinics. Our daycare unit includes 24 adult beds and 18 pediatrics with really very high turnover, i.e. our service run from 7:30 in the morning until 8 p.m. So we are actually able to accommodate sometimes 1.5 double the bed capacity and serve patients smoothly. We have specialized clinics as well, which I'm not going to get into for the focus and the sake of the time. Our inpatient units will start very soon. We are hopefully ready for prime time by October or November this year. And our inpatient unit will include 48 beds unit, in addition to dedicated BMT unit which hold the capacity of 22 beds, in addition to 4 ICU beds within the same floor. So at the outpatient setting right now, we are running BMT clinics. We have 3 specialized clinic, early follow-up clinic, chronic GVHD clinic, and long-term follow-up clinic that are run weekly. We have daycare unit that provides access to supportive care, especially in the first 100 days post-transplant, mainly for hydration, transfusion support, and magnesium replacement, and monitoring their cyclosporin or tacrolimus levels. A Royal Hospital is under the umbrella of Ministry of Health. It is another center that is currently performing autologous stem cell transplant. They have started their program back in 2014, and they are performing autologous stem cell transplant only at the moment. Their transplant numbers up to 2016 were 29. Unfortunately, I don't have access to their most recent data, but they have an estimated annual transplants of 10 per year. They also hold accreditation by Accreditation Canada International. Just to touch base on our outcomes briefly, when it comes to graft versus host disease, we have an estimated rate of acute GVHD of 32%, which is similar what is reported in the literature. Chronic GVHD rate estimated to be 10 to 15%. And again, unfortunately, I don't have any recent data on our GVHD rates, and it will be interesting to see how ATG in a matched sibling donor played a role in our rates, and if these numbers, in fact, are lower than what is reported before. ECB for GVHD was established in January 2023. Again, prior to this, we were sending patients to get access to ECB for chronic GVHD, mainly abroad, where they stay there for months to receive treatment. This was not practical and not really cost effective. So having the ECB in-house now has not only improved patient care, but also lowered the cost of sending patients abroad for such treatment. We have monitored quality of life outcomes in sickle cell disease patients, and I can confirm that they are really doing well. The GVHD rate in general, acute and chronic, reported by patients to be 38.5%, and they have good quality of life post-transplant. We do have challenges. I think it goes without saying that our main limitation is having really limited bed capacity of 4 beds to serve 5 million population. But now, with the infrastructure being expanded and having 22 units, between 22 bed unit in-house, will hopefully solve this problem very soon. And that's why I had left it to the end. I'm being very optimistic about the near future. Donor availability is going to be a problem for us soon. We do have, high probability of having a matched sibling donor for our patients. But as our society structure and demographics changing, having limited and smaller families, I think we will be forced into using either matched related, or haploidentical transplants soon. And that's why we will need to have a very robust donor registry. Of course, complications will remain a challenge, and something to focus on for any transplant center in terms of GVHD rates, infections, and disease relapse. This is just an example of our waiting list. We literally have 268 patients waiting, and that goes to December 5, 2023. And I can tell you, most of these patients are actually sickle cell disease patients waiting to get a transplant, mostly locally. We do send patients abroad, but for sickle cell disease patients who can wait, we are trying to accommodate them locally. So we are hoping that in 2 to 3 years, we'll be able to get to this list and complete it, hopefully, in no time. Our future directions mainly focusing on expanding infrastructure, donor registry initiatives, and continuing in research and having very robust database would actually help into monitoring our outcomes as we are expanding. and of course looking always for regional and international collaborations. In summary, I think it is fair to say, despite having a small program, our data have shown that Oman has a viable and successful hematopoietic stem cell transplant program, and we have established the milestones to continue on and expand on what we have right now. We have performed over 700 transplants in both malignant and non-malignant hematology diseases, and 20 years of experience in transplant is not small. I think we are set up for prime time in no time, inshallah. And hopefully we'll meet in a few years to present our changing numbers. Thank you so much.
Thank you very much. I'll leave the questions to the end after the next.
Sounds good. Thank you.
So our colleagues from the other side, I'll call Dr. Sultan al-Mutlabi for his next talk about his local experience. So Dr. al-Mutlabi is a consultant hematology bone marrow transplant in Nasser Institute for Research and Therapy from Cairo, Egypt. He has worked extensively, like in different positions. He had also many publications and extensive studies in research. He is committed to advancing the field of hematology through his clinical work and research contributions. Thank you very much.
Sure. Assalamu alaikum. First of all, I'd like to thank Dr. Ahmed Al-Askar for his kind invitation and all the committee of the SSBMT. And I'd like to show you our more than 25 years of experience in hematopoietic stem cell transplant. Indications of hematopoietic stem cell transplant according to the CIBMTR: myeloma is the first, followed by non-Hodgkin lymphoma, AML, MDS, MBN, ALL, and other non-malignant diseases. The indications of transplant according to standard of care, clinical option, or developmental, according to each disease and the recommendation of the working group: hematopoietic stem cell sources, either bone marrow stem cells or peripheral blood. More bone marrow stem cells collected under general anesthesia in the operating theater. Peripheral blood collection of hematopoietic stem cells from peripheral blood using cell separator or cord blood stem cells. Hematopoietic stem cell sources: cord blood, bone marrow versus peripheral blood. Bone marrow done under general anesthesia, peripheral blood no general anesthesia. Multiple punctures with bone marrow, not in peripheral blood. Pain at the site of puncture, yes, in bone marrow, not in peripheral blood. Hospitalization required in bone marrow. Engraftment is slower with bone marrow and faster in peripheral blood. Allo stem cell transplant T cell content is lower in bone marrow and higher in peripheral blood. Conditioning regimens used for allogenic hematopoietic stem cell transplant, either REC or MAC. Myeloablative, difference between both: risk of relapse is lower with MAC, higher in REC. Risk of GVHD is higher with MAC, lower with REC. Transplant-related mortality is higher with MAC, lower with REC. GVL is common or more in MAC and REC. Indications: younger patients and with no comorbidities are indicated for MAC. REC is indicated for older patients or with comorbidities. This is the centers participating with the CIBMTR. We are there. Egypt has almost 13 or more than 13 transplant centers today. Nasser Institute is the biggest and the oldest one. We have 30 cabins for transplant. Numbers we did through the years, a lot of years, past years. We did almost more than 8,000 transplants through this more than 25 years. The challenges of bone marrow transplant in Egypt: lack of donor related, lack of matched unrelated donor. In Egypt, only 40% of patients who have siblings are expected to have HLA identical donor. Less than 30% of donors listed in the international registries are of Oriental origin, which makes it difficult to find a matched unrelated donor. HLA haploidentical stem cell transplantation is another alternative treatment modality where only one HLA haplotype is matched with individuals. We started haplotransplant since 2016. Haplohematopoietic stem cell transplant is alternative for patients who didn't have a fully matched donor. Recipient challenges for hematopoietic stem cell transplant: comorbidities, wait list, source of stem cell, socioeconomic status, consanguinity and certain genetic diseases, GVHD risk and management, minimal residual disease assessment, availability and cost of new drugs. Allogenic hematopoietic stem cell transplantation statistics in Egypt: overall survival in Nasser Institute around 64% for all categories, all diseases. Allogenic hematopoietic stem cell transplant for malignant hematological diseases. Indications of AML transplant, you all know that. CR1 clinical options for intermediate and high risk, we do a transplant as a standard of care or more than CR1. Matched related donor allogenic hematopoietic stem cell transplant for AML overall survival by CR in Nasser Institute in patients less than 18 years, around 60 overall survivors, around 64%, 74% in CR1, around 67% in CR2. Overall survival for matched related donor hematopoietic stem cell transplant AML patients by CR for patients more than 18 years, around 65% in CR1, around 51% for more than CR1. Also, according to the SSBMT data from the USA shows that the overall survival in AML patients in CR1 less than 18 years, it is around 75%. In CR2, it is around almost 70%. Also, survival after matched related donor hematopoietic stem cell transplant for AML patients more than 18 years in the USA, for CR1 it is around 60%, for CR2 it is around almost 55%. Hematopoietic stem cell transplant in MDS, it is we did a transplant for refractory anemia patients who are refractory to treatment, refractory anemia with excess blasts, or refractory anemia, or patients with transformation to acute myeloid leukemia. Matched related donor allowed hematopoietic stem cell transplant for MDS in Nasser Institute shows that overall survival around 52%. Survival for hematopoietic stem cell transplant myelodysplastic syndrome for patients more than 18 years in the USA, also it is around 55% for matched related donors. Indications for ALL transplant: we transplant patients with ALL with high risk cytogenetics, or didn't achieve negative MRD, or patient more than CR1. Matched related donor allohematopoietic stem cell transplant for ALL patients, event-free survival by CR for patients who are more than 18 years, it's around 65% for CR1 and around 55% for more than CR1. Survival after matched related donor hematopoietic stem cell transplant for acute lymphoblastic leukemia more than 18 years in the USA, according to SSBMT, it is also around 60% or 65% for CR1 and 55% for more than CR1. Hematopoietic stem cell transplant for CML, almost all didn't do hematopoietic stem cell transplant for CML, but we still do that for patients who are chronic phase, who are resistant to more than one second generation TKI. We use MAC. MAC doesn't offer advantages for RIC over RIC. Patients should be monitored after transplant by QR-PCR and treated with TKI or DLI if it's started molecular relapse. Patients in accelerated phase who didn't achieve an optimal response with the TKIs. Patients in plastic crisis, we should intensive chemotherapy and TKIs, then followed by consolidation by allostem cell transplant. Allogenic transplantation in benign hematological diseases. Benign disorder transplant, we did transplant for sickle cell, for severe aplastic anemia, beta thalassemia. Sickle cell, we didn't have a long experience with it. matched related donor transplant for severe aplastic anemia by age for patients more than 18 years, for patient less than 18 years of old, overall survival around 75%. For patients more than 18 years old, it is around 55%. Survival after allogenic hematopoietic stem cell transplant for severe aplastic anemia in the USA in patients less than 18 years, it is almost around 90%. Survival after allogenic hematopoietic stem cell transplant for severe aplastic anemia in patients more than 18 years, it is around 85%. Beta thalassemia major, it is the most common hereditary hemolytic anemia. The incidence of carrier state is 9 to 11%. Allohematopoietic stem cell transplant is the only treatment modality that eradicates the thalassemia clone or reach a stable chimeric status to avoid blood transfusion. Overall survival of beta thalassemia patients after transplant, or for all categories, class 1, class 2, class 3, it is around 85%. Overall survival of beta thalassemia patients after allohematopoietic stem cell transplant per stem cell source, for those who received the peripheral blood, overall survival was around 85%. For those who received bone marrow stem cells, is around 83%. Autologous transplantation, overall survival for multiple myeloma patients after auto transplant in Nasser Institute, overall survival around 45%. According to SSBMT in USA, it is almost the same or higher a little bit. Overall survival of non-Hodgkin lymphoma patients after auto transplant around 60%. Also, in diffuse large B-cell lymphoma for auto, the outcome is 60% almost. Overall survival of Hodgkin lymphoma patients after auto transplant, it is around 65% in Nasser Institute. Thank you.
Thank you very much for your concise bullet points. I'll call you to the stage if we have some questions, both of you, Dr. and Dr. Shuraya. Few minutes, as you gave us a few minutes from your presentation also. So anyone has questions for them? Anyone has a mic?
Yeah, thank you. Very nice presentations. And Dr. Thuraya, you mentioned you have more allogenic
Correct, yeah.
transplants than autos, and it's way far. What do you think the reason is?
I think one of the part of it is the number of physicians responsible to treat lymphoma and do autologous stem cell transplant. Dr. Khalil Parsi, I think you are familiar with him. He is the only lymphoma consultant in the center, and he has been handling all the lymphoma and autologous stem cell transplant cases until last year. He has now more help, but he has 2 additional consultants in leukemia and autologous stem cell transplant. So we'll see higher numbers. The other thing is I have to look at our frequency of lymphoma cases and how many of these out of these cases require autologous stem cell transplant. The other thing is we have a second center, like Royal Hospital is also performing autologous stem cell transplant. So if we look at both numbers combined, I think we are going to be close to where what is the percentage of autologous stem cell transplant being indicated and performed. And of course now with more advanced therapy, accessibility to biopsy, we still don't have any access to CAR T yet, but we have started the treatment abroad pathway. We might see these numbers even smaller than what we have right now.
And maybe the hemoglobinopathies, that's also shifted the care.
It did as well, exactly, and not even counting the patients who received a allogeneic stem cell transplant for hemoglobinopathies abroad. That is quite
Thank you, Dr. Thuraya. You mentioned the challenges of the donors because the population is changing and non-sibling donors may not be available, which is true all over the world. So the donor registry, unrelated donor registry is important, but do you think it's more important to just set up the fundamentals of a world-class haplotransplant program rather than focusing on that? And the world-class haplotransplant program includes HLA immunologists who are experts in C1Q, DSAs, HLA DPP1, and others, and obviously looking into the desensitization protocol, refining and perfecting them, rather than having a unrelated registry. Thank you.
I totally agree and concur that 100%. And I mean, even haploidentical stem cell transplant is getting better by year and more optimized. We're actually looking into starting our own trial because, as you know, like haploidentical stem cell transplant is not the standard of care in hemoglobinopathies and like sickle cell disease. And we do have a list of patients waiting for transplant for very good indication like cerebral impact, sickle cell, CNS disease, and they actually don't have a matched sibling donor or match-related donor. So I think haploidentical would be the easiest way to access to get access for these transplants. But I still think we still need to have a donor registry because we still not have haploidentical approval as a standard of care for every single indication, right? So that's where donor registry might be crucial.
Yes, I think we have more time. Yeah.
Sure, Dr. Mutwalli. So what's the situation with the haplo? Do you do haplo transplant?
Yes, we did have.
And the unrelated and the, again, stem cell donors and others. What's the situation in Egypt?
We started haplo program since 2016. We did a lot of haplos, and even we used both sides for matched sibling as a prophylaxis for GVHD. After we started using it was haplo, we have almost around 16 beds for haplo transplant. But haplo still not covered by governmental, only on private sector. Or patients have private insurance or other insurance non-public. So we did it in the Nasser Institute, didn't add for the results, but we did have blue transplant since 2016 for what is indicated. We have lab for desensitization. We was doing desensitization. Last days we even stopped to do this, and we are going well.
Other questions? Dr. Mutwalli, mashallah presented, you have a major big number, so you even presented the autologous, the myeloma patients or whatever, and like I saw you had like long follow-up for these patients. So these are like your data presented is collected until up to like now, or was it only until
almost last year?
23?
Since 1997 till last year.
MashaAllah. I actually had a small question for Dr. Thuraya that is similar to Askar. Like, did you have like a question the other way around for autologous? Like, are you facing any issues with like lab or cryopreservation that led to the like you don't have so much numbers of autologous, or it's only maybe just operator dependent?
I think it might be operator dependent and having two centers combined with autologist. And as I mentioned in my presentation, I actually don't have access to the most recent data of autologous numbers that are done at Royal Hospital. So for allergenic, we have unified our numbers because it's only done at Sultan Qaboos University Hospital. But when
for their time and sharing their local experiences. And I think we have some time, so there is prayer and break. So thank you very much.
start our third session for today. It's going to be about CAR-T and auto transplant and multiple myeloma. It's my pleasure to introduce my colleague and friend, Dr. Badr Al-Ahmari, for the first talk. He's a consultant hematologist and stem cell transplant at King Abdulaziz Medical City in Riyadh. He is also the chairman for the blood and cancer research at KMARC. He is going to talk to us about a special population who are very difficult to treat, diffuse large B-cell lymphoma patients with primary refractory disease. So, Dr. Badr, thank you for joining us, and the floor is yours.
All right, assalamu alaikum wa rahmatullah. Welcome back again. Thank you, Dr. Abdullah, for the nice introduction, and thank you for the SSBMT and KITE for the invitation for this satellite symposium. So, as we know, many years ago, R-CHOP became the standard of care for treatment of diffuse large B-cell lymphoma, and we were able to cure actually majority of those patients with a median overall survival of 8 years versus 3 years, with the addition of rituximab to the backbone of CHOP. However, despite of that, 40% of patients, they will eventually relapse, and actually 10% from all comer, they will be what we call it primary refractory disease, who they have dismal outcome. And as you can see here, the median overall survival is very dismal for those who relapse after the R-CHOP upfront therapy. Of course, we will be able to cure some of them with the use of high-dose chemotherapy and autologous stem cell transplantation. However, many of those patients, they will not be able to either respond to this treatment or tolerate this kind of intensive treatment. And this is a retrospective review from a single center showing that there are some marker, what we call it ultra high risk features, and that's including primary progressive disease, MEC positivity, and high, intermediate high, and high NCC and IPI. If patient has one of these markers, one or more than one of these markers, the outcome will be very dismal. Identifying a subset of patients that they are highly refractory to the upfront use of high-dose chemotherapy. Similarly, the SCHOLAR-1, which they pull data from 2 phase 3 trials and 2 observational cohorts, and they found a similar finding that the response rate is very dismal for those patients, around 26%, only 7% complete remission. And if you look to those who are primary refractory, the response rate is only 20%, with a median overall survival of 6.3 months. Very dismal outcome in those patient population. So, for patients who are highly refractory to chemotherapy, we know that in general, cancer cell, they have a way to evade immune system, and evading this by upregulating certain molecules or secreting certain signaling molecule, TGF-beta, upregulating of the BD ligand, that will help the tumor cells to evade immune system. And actually, T cell have certain ways to navigate the immune system and clear the tumor. Of course, you need those tumor cells to release certain antigen, and this antigen has to be presented in a nice way to the T cells and recognized by the T cell. The T cell has to traffic to the site of the tumor cells and engage with the tumor cells by recognizing them. So the recognition is a very important aspect of the T cell to exert its function against the tumor cells. And then followed by the killing. Checkpoint inhibitor have been a great groundbreaking into the novel intervention and immunotherapy for cancer in general and some of the lymphomas. But unfortunately, this did not work with the diffuse large B-cell in general, not even cancer vaccine and others. However, improving recognition has been the key here, and CAR T cell help actually to improve the recognition of the cancer cells and direct killing of the lymphoma cells. So, what is cancer? So it is modified T cells that is genetically modified to express certain molecule that facilitate the T cell to recognize the tumor cells, and then they exert its effector function and kill the cells. And how we do that? By collecting the patient starting material, leukapheresis, sent to the manufacturing facility where the T cell expansion, selection, isolation, and activation and expansion happen, and then the transfection with the viral vector that will lead to the expression of the target of interest, either CD19 or BCMA, for example. And then this cells will be shipped back to the treating facility and will be infused to the patient after a lymphodepleting agent. And then the T cell will actually recognize easily the lymphoma cells and exert its effector function. We have now around 6 products with the target including CD19 and BCMA, and those 6 products covering more than 12 indications so far. But what we want to focus on in our talk today is the CD19 target, and specifically for treatment of highly refractory or primary refractory diffuse large B-cell lymphoma. I'll start to talk about axicabtogen lysolysyl, which is in short we call it Axicel, for the use of this product in the second line therapy for large B-cell lymphoma. I'm talking about specifically here the ZOMA-7 study. In this study, they tested the use of Axicel in a randomized fashion against the standard of care in a primary refractory patient age more than 18, who are refractory, relapse refractory less than 12 months, or they are primary refractory to the first line of therapy. Patient has to be intended for high dose chemotherapy. That means they have to be fit in terms of ability to withstand the salvage chemotherapy and high dose autologous transplant. Then patients were randomized to Axicel or use the standard of care with platinum-based chemoimmunotherapy. And for those who achieve CR or BR, they will go to autologous transplant. And the primary endpoint was event-free survival. The median age was, as you can see here, around well balanced between 2 groups, around the age of 60, and this is what we see usually for patients who are fit for autologous transplant. However, you can see here that around 1/3 of patients actually they're aged more than 65. Of course, majority of patients they have advanced stage and advanced IPI, and 70% of patients they were actually primary refractory. Majority of patients they were actually diffuse large B-cell lymphoma. Very minority of them they were actually they have the rearrangement, the double hit or triple hit. The study met its primary endpoint with median overall survival for those who received Axicel was 8.3 months versus, median event-free survival for those who received Axicel was 8.3 months versus 2 months only for those who underwent salvage therapy and autologous stem cell transplant, and after a median follow-up of 24.9 months. And the 2-year EFS was 41 versus 16%. Overall response rate was actually higher in the patient treated with CAR-T, 83% versus 50%. Majority of these were actually CRs of 65% versus 32%. In terms of toxicity, around 6% of patients they have 3 or higher grade of CRS, and median onset was around 3 days. Looking into neurological toxicity, 21% of patients in Axicel they have grade 3 or higher neurological toxicity versus only 1% in those who are treated with the standard of care. Median onset time to the neurological toxicity was 7 days. Longer follow-up showing that actually Axicel led to improvement in the overall survival compared to standard of care. After a median follow-up of 47.2 months, the median overall survival was not reached in the Axicel group versus 31 months in the standard of care patient. Despite that, 50% of standard of care patients they went on and received subsequent cellular immunotherapy, which most of the protocol, which most likely would be CAR-T cell at that time. Some data for quality of life showed some measures of improvement of the quality of life for those who receive Axicel versus standard of care, especially within the 100-day post procedure. And this is set the standard for Axicel to be the standard of care as a second line for relapse refractory or primary refractory diffuse large B-cell lymphoma. Another agent is the Lysocell, which is again CD19 CAR T cell. This was also tested in a randomized fashion in the same patient population, relapse refractory less than 12 months, as who failed first line therapy with the primary endpoint of event-free survival. In this study, it met its primary endpoint with median EFS not reached versus 2.4, but this is after a shorter follow-up. The median follow-up was only 17 months, and the median overall survival was not reached versus 29 months for the standard of care. Again, high response rate versus standard of care. And what's interesting here, the adverse event was lower. If we talk about grade 3 CRS and higher, was only 1%, and grade 3 and higher of neurological toxicity of only 4%. So we're talking about patients who were actually have primary refractory DLBCL and they are eligible for intensive chemotherapy. So what about those who are not eligible for intensive chemotherapy? There are two pilot studies that we would like to discuss today. For the Axicel, we have the Alicante study. It's a phase 2 study, including patients who are not fit, who are refractory to the first line of therapy and not fit to go for intensive chemotherapy. Those patients, they actually roll into this study, and they allow in this study to do bridging, while in the Axicel, the Zuma 7, they did not allow bridging chemotherapy. And the criteria to go into this study was aggressive B-cell non-Hodgkin lymphoma, including DLBCL or high-grade DLBCL or high-grade follicular lymphoma. And the inclusion, the criteria for not to be eligible is by physician assessment plus one of the following criteria, which is age above 65 or younger age who had high comorbidity index of 3 or more, or those who have prior autologous transplant. The median age was around 70, and the refractory to first line was around 50% of patients. They are refractory to the first line of therapy. And the bridging chemotherapy, which is R-GemOx, was used almost in all patients. And the response to bridging therapy was not significant. With the 50% of patients, they have either stable disease or progressive disease after the bridging chemotherapy. The complete response was around 71% investigator assist, and centrally assist was around 66%, which is quite impressive. With the best response was around the complete was 3 months, but the best response later on was around 90% overall, with the complete response of 79%. The median, after median follow-up of 12 months, the EFS was the median EFS was at 12 months, 12.3 months. And the median overall survival was not reached, with estimated 1 year overall survival of 78%. Again, grade 3 to 4 CRS was 8%, which is a little bit lower what we expect. And also the ICANS was around 14% grade 3 to 4. There was around 25% ICU admission in this study, and non-relapse mortality was around 9.7%, which is considered not an easy treatment to do. Another study testing the Lysocell, the same patient population, which is the pilot study. Again, this is a single-arm, open-label phase 2 study. They include elderly patients who failed the first line of therapy, and then they are not eligible, they are not fit to receive intensive chemotherapy, showing again 80% overall response rate with a 50% CR rate, with after median follow-up of 15 months, the median PFS was 9 months, a little bit shorter than what we see with the Axicel, and median overall survival was not reached, with a 1 year probability of overall survival of 70%. With that, I conclude and happy to take a question. Thank you for your attention.
I think we have some time for questions. You finished up before the time. Any questions from the audience?
Thank you for an interesting talk. Can I just ask how you make decision about what product to use? If you have a patient and you want to decide, what factor you take as you go to one or another?
So the factor one is what is available. So what's available there and easily accessible to the patient. This is what you are to do, because both products they showing efficacy and safety profile. Similarly, the success in their study they were not compared head to head, which is the best ultimate way to make the best decision, right? But both are approved, but one of them is available and one of them is not available. So that's basically the decision. And manufacturing ease, you don't want your patient to wait. So that's, I think, this is one of the major factors, which one you can deliver to your patient, and everything else is manageable. Because both of them, they were effective and they show improvement in EFS and longer follow-up showing improvement in overall survival, especially in the accessor.
Some prefer the lysosome for the older people because of the side effect.
Maybe. I mean, they do have better toxicity profile, okay, but we're not able to compare head to head in this situation.
Any other questions? I have a question for you. In real life, it's difficult because most CAR Ts are at centers where the referral has been done to the center, and most of these patients will come sick and they need bridging therapy. In your experience, are you getting similar results of what you see in the Zuma 7? Because in the Zuma 7, only steroids were available as bridging, but in real life, we have to use bridging before CAR T. So what are your thoughts?
Correct. I mean, the bridging therapy was not allowed in Zuma 7. They allow only use of high-dose steroid in that situation. But if the bridging therapy happened in the patient after the collection, I don't know how much impact will have using the bridging therapy. But we don't have specific data whether bridging therapy versus no bridging therapy, which one will work, right? I mean, so you might have select to the worst of the worst if the patient are refractory to bridging therapy. But we can extrapolate from the data from Alicante study, because more than 90% they receive R-GemOx, which is somehow that's what we usually do as a bridging therapy. We don't do more intensive bridging therapy, and 50% of patients did not respond. And yet we have an excellent data based on phase 2 study. You can just extrapolate from that one.
Thank you, Dr. Badr, for your comprehensive presentation. To complete the question of my colleague, Dr. Abdullah, you mentioned that this group of patients, when they have primary refractory, their prognosis will become poor, especially if they receive the second line, and if they do not respond, the prognosis will become dismal. So can you address again, since all colleagues from the kingdom here, about the importance of early referral and definition of primary refractory, and how important the early referral for?
Correct, yeah. I mean, so those patients, they have a dismal outcome. And based on what the data that I presented early on in the presentation, those who are really refractory to the first line chemoimmunotherapy and they did not achieve CR even after chemoimmunotherapy, they do have a poor outcome. And I think early recognition of those patients and referral is a key and a crucial, because adding more line of therapy will make even collection of the cells difficult, and making patient fitness and eligibility for CAR T cell might be impaired at that time. But this is really an important key. Just when we identify those patients, immediately refer them and then so we'll be able to collect the cells, and then we can do whatever after that. So universally, we do bridging therapy. We don't stick to the criteria that was mandated by the Zuma 7 in real life.
Thank you, Dr. Badr.
Thank you.
Discussion. We'll move to the next speaker. Next talk will be given by Dr. Ibrahim Al-Munas. He's a consultant and acting chairman at the Department of Pediatric Oncology Hematology at King Faisal Specialist Hospital and Research Center. His main area of interest is bone marrow failure, acute leukemia, myeloid and lymphoid, and stem cell transplant, immunotherapy. He's going to talk to us about the local experience of CAR-T at King Faisal Specialist Hospital. Thank you, Dr.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everybody. Would like to start with thanking the SSBMT Society on this invitation, and would like to thank personally Dr. Ahmed for his kind invitation. It's my pleasure to be with you today talking about our experience with CAR T cell at King Faisal Specialist Hospital. So I will try to summarize the topic today in outlines, starting with a quick introduction. Then we'll touch base briefly about the CAR T therapy programs at King Faisal Specialist Hospital and Research Center in Riyadh, following by patient treatment journey. Then I will present our experience and will present our pediatric data today. Then we'll talk about some challenges and obstacles in facing of these very challenging patients. Despite the significant advancement in the treatment of B-cell ALL, still the relapse and refractory disease remains a challenge for ALL patients. Relapse refractory B-cell ALL face very limited treatment options and poor prognosis. And before we have the CAR T cell, most of them they will be palliative care. CAR T cell therapy offers a novel therapeutic approach, and the first CAR T targeting CD19 product was approved in 2017. The efficacy of CAR T cell therapy targeting CD19 in pediatric and young adult patients with refractory relapsed B-cell ALL was observed in clinical trials with high remission rates and durable responses. The CAR T cell therapy has demonstrated efficacy, but on the other hand, it's present unique challenges. The side effects like the cytokine release syndrome, ICANS, prolonged hematological toxicities with the thrombocytopenia and neutropenia, and B-cell aplasia leading to hypogammaglobulinemia and increased risk of infection were reported, and it's a major part of taking care of this patient that you should be on top of these things. In Riyadh, so initially we have the initial feasibility assessment phase for the program began in the fourth quarter of 2017. With that, the CEO asked Dr. Ali Al-Ahmari to lead this program. Then the CAR T cell project team developed various committees and subcommittees to assess and determine the requirement of developing and maintaining the program. Clinical working groups initiated to safeguard the development of the required clinical practice, governing and training documents. Required documents were developed, staff training was initiated. The first patient was infused on 20th of December 2020. 20. Nowadays, alhamdulillah, we are approaching 150 CAR T cell therapy at King Faisal Specialist Hospital in pediatric and adult. All program developments, both operationally and clinically, as well as outcomes, are reported by the program chair to the MCA. Here is the program structures. We'll have the CAR T clinical coordination meeting, which will include the adult and pediatric CAR T cell teams and the quality coordinator. You will have the CAR T laboratory coordination meetings, which involve the blood bank and the stem cell processing lab and pheresis unit and the quality coordinator as well, and the CAR T administrative planning meetings. They will report to the CAR T program oversight committee, and they will report to the chief medical officer. CAR T program is not easy. You should build your multidisciplinary team. You have the core CAR T teams with the medical and nursing and coordinators. You need excellent collaboration with the pharmacy, with the apheresis stem cell lab and the manufacturing facility. And you need to have supporting teams, including the ICU, neurology, ID, emergency department, late effects, looking to the psychosocial support, and have good trials and outcomes research to see your results and express it to the national and international groups, and to learn from your experience. How the CAR T cell work, as you know, so we'll collect the normal T cell, where the virus is used to inject modified DNA into the normal T cell. After that, the genetically modified DNA produce a cancer-specific CAR T on the surface of the T cell, which will be a killer, and it will lock to the cancer cell, end by cancer cell death. Patient journey will start by leukapheresis of the patient. Then the product will ship to the manufacturing facilities, where the T cell will be activated and expand. Then it will come back to the treating center, where you will give your lymphodepleted chemotherapy, and you will infuse the T cell for the patient. After infusion, you will look for the CAR T cell toxicities, cytokine release syndrome, ICANS, infections, febrile neutropenia, organ-specific toxicities are expected. Kymriah is the product that we are using for our pediatric ALL patients. As you know, Kymriah is approved for pediatric, young and adult patients up to 25 years of age with CD19 positive B-cell ALL that is refractory or in relapse post-transplant or in the second or late relapse. It indicated as well in the diffuse large B-cell lymphoma in adults with a relapse on refractory diffuse disease. What's the indication for CAR T cell in pediatric? So what we are doing is screen our patients and the referring cases for the eligibility criteria to have the CAR T cell. Refractory to first line is one of the indication when you are failing to put the patients in remission, to take the patients to transplant, then you may over CAR T cell therapy. If you have refractory first relapse, the patient relapse and it's refractory, you could not put them in remission to proceed with the transplant. So it's another indications for patients to go to CAR T cell. Second or greater relapse is an indications even if this patient did not had transplant before. if you have patients non-eligible for transplant, you have comorbidities that this patient will not tolerate the transplant, like the Down syndrome. Usually we didn't take them to the transplant, so CAR T cell can be option for these patients. Any relapse after the transplant is an indication for CAR T. So you'll start the screening of the patients, work up prior to before the apheresis. Then you will arrange the leukapheresis and the bridging chemotherapy in collaboration with the referring centers. Then once you have the product back, you will admit the patients in our unit for CAR T cell infusion. So patients, normally they admitted for CAR T infusion for 15 to 20 days. We discharge them after day 14, usually once neutrophils recovered and the patient is stable and afebrile. Patients will be discharged with CAR T cell alert badge, and paper chart will have CAR T alert sticker on the cover, so if the patients drop in the ER or other area, the sticker will be alerting the people dealing with the patient that this patient is post-CAR, as well as the ISIS documentation will have alert in the documents indicating that this patient is post-CAR. After discharging the patients, we ask them to stay in Riyadh for up to for like 2 months, like up to 8 weeks. They are coming in the clinic once to twice per week as indicated. Patients may be at risk for having CRS, ICANS, and infections after discharge, so the outpatients team should be conscious about these important factors. If unwell, if the patient unwell, they will attend to the treatment area during working hours, and they will go to the ER after hours. These are the stickers that usually the patients will carry, and it will be on the cover of the patient's chart. The pathway steps that it's really important to be clear between the referring centers and the CAR T cell centers. You know, these patients are sick, and they are most of them, they need kind of inpatient and outpatient care, and it will be extra load on the tertiary centers who's doing the CAR T to deal with all the treatment aspects. So having a clear pathway between the two centers is really a key factor. Once the let's say oncology center is having a patient that may benefit from CAR T therapy, they should be discussed in the center's tumor board, agree about the CAR T eligibility. Then they will contact the CAR T cell centers. You will discuss the patients in the CAR T cell centers in multidisciplinary team, will repeat the biopsy for confirmation of CD19 positivity. Once we have the confirmation, we'll start to work for the leukapheresis readiness as soon as we can. Then you will coordinate the bridging chemotherapy and the washout period between the two centers. The bridging chemotherapy is like a balance between controlling the disease and reducing the toxicities. We didn't ask the patients to be in deep remission before CAR T cell. You can take the patients to the CAR T cell even if they have some disease burden, but on the other hand, taking the patients with heavy disease burden is a challenge, where you expect the risk of relapse will be higher and the risk of the toxicities will be higher. So balancing these two factors is really important when you are dealing with the bridging chemotherapy. Once we have the patients is ready for CAR T cell infusion, will be admitted and will be infused, and you need patient follow-up and the treatment outcomes and adverse events in well designed outpatient setting. So what about the pediatric data from King Faisal Specialist Hospital and Research Center? Here is our inclusion for the data that I will present. So I'm presenting here the pediatric patients below 14 years of age have CAR T-cell for relapse or refractory ALL at our department between December 2020 and July 2024. So time frame, as we mentioned, so from December 2022, where we have the first case, till July 2024, total patients, we have 28 patients underwent 29 episodes. We have one patient that we did 2 CAR T because this patient relapsed with CD19 positive disease, so we offer second transplant for him. 60% of the patients are male and 40 were females. The median age from is 8.1 years, ranging from 2.6 to 13.2 years. Pre-CAR T-cell transplant status, we have almost half of the patients never transplanted, and we have the other half had single transplant before they come for CAR T. What's the type of the relapse? Isolated bone marrow in the majority of the patients, up to 65%. We have 19 patients with isolated bone marrow. We have 6 cases with isolated CNS, and we have 4 cases with combined bone marrow and CNS relapse. Looking to the pre-CAR T-cell treatment received, 40% of them, they got chemotherapy, they relapsed and referred to the CAR T without a prior transplant. We have 6 patients chemotherapy and transplant before the CAR T, and we have 6 patients with chemotherapy, immunotherapy, including either blinatumomab or inotuzumab before the transplant, and we have 5 cases with chemotherapy and immunotherapy. CAR T-cell dosage, the median is 3.2 million per kg, ranging from 1.5 to 1.2 to 5 million. The median dose in ml is ranging from 10 to 34 with a median of 20 ml. The first admissions median was 24 days, ranging from 15 to 117. 117 this is like special case that is relapsed shortly and kept in patients for a long time. So most of the patients, they will ranging from 15 and 20. Our incidence for CRS, we observe it in 18 out of 29, so that's 62.1%. Grade 1 in 7%, grade 2 in 31%, and grade 3, 24%. We didn't have any grade for CRS in our cohort. ICANS, all ICANS observed in 3 out of 29, that's 10%. 2 cases grade 4 and 1 grade 1. We have 2 cases with status epilepticus that requiring ICU admission, so it's classified as grade 4, and we have 1 grade 1 ICANS. ICU admissions, we admit 13 out of 29 in the ICU. The median days in the ICU was 5. Inotropes was given in 8 of 29 with grade 3 CRS. Hematological recovery, if you look to the ANC recovery, the median is 14, ranging from 2 to 71. We have most of them, they recovered within day 28, and we have 1 patient who never dropped, and we have patients, 5 patients never recovered within 28 days, so they recovered after. Platelets, the median is 29.5, ranging from 11 to 57 days. Comparing our incidence of CRS with the benchmark studies, they are like we have 62 in Ileana, the incidence was 77%, and in the CIBMTR registry with 25 centers from from the North America was 59. This is the ICANS incidence in our centers comparing with the others. Probably we having less cytokine ICANS complications. Overall survival, these are the curve with our overall survival. We have it 70.5%. The median follow-up is 13.5 months, ranging from almost 5 to 22 months. Then the overall survival, depending on the kind of relapse. So if you observe here, we have, as we mentioned, we have 4 cases with combined bone marrow and CNS. All of them, they are still alive. For isolated CNS, we have 1 mortality case post-transplant related to the toxicities. When we have the isolated bone marrow, so they are overall survival was 64%. So they are the lower in the group. Here is the event-free survival. If you noticed here, so overall is 58, but we have relapse. Unfortunately, is continuous dropping. So the line is declined. It's never a plateau. That's raising the concern that CAR T cell seems to be not standalone treatment as we believe, since we are observing even late relapse. So we have the first 2 cases that it's almost 3 years post CAR T, they relapsed recently. So this is raising the concern of continuous declining of the event-free survival curve in our cohort. This is the event survival based on the kind of the relapse. If you see here, the bone marrow relapse is doing worse, and they have a higher percentage of relapse and death after the CAR T. We lost 1 patient. We have 1 relapse in bone marrow and combined bone marrow and CNS, and we have 1 mortality in CNS relapse, isolated relapse with toxicities related to the transplant. So here is looking to our overall and event-free survival comparing with the benchmark studies. It's comparable to the international groups. If you look here, this is the our outcomes with CIBMTR registry. Even with the CIBMTR data, they are declining in the event-free survival curve and the overall survival. So that's highlighting the risk of relapse even after good times post-transplant. With Ileana study, again, there is a continuous dropping in the event-free survival. If you look to the outcomes at 6 months, it was 71, then it dropped gradually to 44 at 36 months, and maybe will be less after longer follow-up duration. So that's raising the questions. Is the CAR T cell can be a standalone, or you need to consolidate the CAR T with transplant? It's really difficult questions. Probably transplanting all of the CAR T cell, maybe it's too much and like over treating, while on the other hand, if you give the CAR T and just CAR T therapy without transplant, maybe you are under treating some groups of patients. Trying to answer this, we look to our data. and comparing the outcomes of patients underwent transplant post-CAR T, comparing with patients who got only CAR T, and there is trend showing that there is better outcome when you transplant the patients post-transplant, post-CAR T. Again, for event-free survival, again, the trend is طبعا small يعني sample size, so the p-value is not significant, but there is trending better outcome when you take these patients to the transplant. So the questions, which group of patients you may consider them for transplant post-CAR T? We have some criteria that we all and most of the international groups agree on, and there is a gray area that it's really need very extensive evaluation of the patients and discussion to decide which of them should go for transplant. If you have infantile and non-infantile leukemia with MLL rearrangement, definitely you will consider the transplant post, because there is a risk of lineage switching in this group. If you have positive MRD post-CAR T-cell infusions, this is an indication for transplant. What's the timing that you take it in consideration and take this patient as positive MRD? Probably between 60 and 90 days. Definitely day 30 is still early. You may have positive MRD. You will give more time for the CAR T to work. By day 90, if still there is positive MRD, the risk of relapse will be high, and considering this patient for transplant will hopefully give a better outcome. Early recovery of normal B cells on the routine lymphocyte markers monitoring. Again, the timing is there is conflict about which time you will consider it early. Definitely less than 6 months of B cell recovery, that's indicate weakness of the CAR T, and the CAR T is getting function is getting less and less, and the risk of relapse will be high. So we all in our centers agree that early recovery of the B cell less than 6 months is an indication for transplant. After 12 months, if the patient clinically is fine with negative MRD, there is no indication for transplant. Between 6 months and 12 months is the gray area that you may have conflict and different opinion. If you have remaining bags at the manufacturing lab, you may consider reinfuse of the CAR T when you have early B cell recovery. But if you don't have, so definitely this patient should go for transplant. What we are discussing now, and probably it will be our next direction, is transplanting the patients post-transplant if they didn't have a previous transplant. So if you have, even if the patient is doing well, achieve remission, still we are observing relapse. So probably consolidate the transplant, the CAR T cell with transplant in well preserved patients is a way to go. If you have patients who had transplant before the CAR T, it will be really toxic to take them to the transplant unless they have positive MRD or strong indications. So that's the, let's say, the bright aspect of the CAR T cell program. But on the other hand, we have a lot of challenges. Remember, these patients are very sick, and a few years ago they are palliative, so they will be referred to you to take care of them. Some of them, they will come with an impression that it's the CAR T is very easy, and it's like a piece of cake, and it's easy to put the patients for CAR T, but this is not the reality. You may have difficulties in collecting the T cell due to disease progression. If you have like very active disease with peripheral blast, let's say more than 80%, and there is no normal neutrophil, so you could not collect the normal T cell. So these are issues. You may have a trial of collection, then you will send it for manufacturing, but it may get failed before because the low count. You may collect and send, but it's failed due to contaminated product. And we have it in two cases that we sent this and the product was contaminated and we recollect again. You may collect, manufacture, and the patient has uncontrollable disease and get sick and not ready for having the CAR-T infusion. We have patients who we were unable to infuse because the active GVHD, and you know the active GVHD is contraindications for CAR-T. Heterogeneity of the CD19 is a really important point to discuss and be sure with and review it for every single case with our colleague in the hematopathology. You should have a homogeneity of CD19 expression. Having patients with partial expression of CD19, you may have the other clone get relapse after the CAR-T. And we have one case like with partial expression and relapse shortly after the CAR-T with CD19 negativity. Going back to the previous reports, they look and say, okay, this is partial expression, not full expression of CD19. So taking this point is really important. You may delay the CAR-T in patients if you have unresolved serious adverse reactions, if you have active and controlled infections, active GVHD, and significant clinical worsening of leukemia burden, that's lead to a delay in the CAR-T infusion. So the conclusion, CAR-T cell therapy over the novel, a therapeutic approach, and hopefully in the near future we'll have more CAR-T product targeting more cells. It gives high rates of remission and durable responses. It seems that it's not standalone treatment, at least in a group of patients. A transplant post-CAR-T seems to increase the overall survival and event-free survival that may consider and balance it with the toxicity, the expected toxicity from the transplant. Thank you for your listening, and would like to thank all the people who's working for this program, starting with the higher administration of the hospitals and the core CAR-T programs and all the multidisciplinary teams and all of our patients and their family. And thank you for your listening.
Thank you, Dr. Ibrahim, for this comprehensive talk. Any questions from the audience?
Thank you for the presentation, Dr. Ibrahim, for interesting topics. I have a question for you about the CAR-T cell, about pre-CAR-T cell treatment like chemo and immune therapy like Blina. How's the efficacy about CD19 during this procedure?
Yeah, this is good questions, Dr. Umar. In the literature, previous immunotherapy is associated with poor outcomes post-transplant. So when you have patients get Blina, the washout period is long, so that's one of the challenge. Then you should make sure that your patient is CD19 positive, because giving the Blina may put the patients in CD negativity relapse. So even if you have patients with Blina or Intuzumab, but still the patient expressing CD19, the CAR-T is an option, taking into consideration the outcome may be less. So the message, if you have patients with refractory disease and you think the immunotherapy will not put the patient in a status that this patient can go for transplant, so early recovery, early referral for CAR-T is the way to go. So consider to the CAR-T centers about these options. Giving the Inotuzumab or blina, it will delay the CAR T يعني infusion, and it may reduce the outcome after the transplant, after the T cell infusion.
Any other questions?
Yeah, thank you, Dr. Ibrahim, for the presentation. Congratulations and for the program. Question about the rate of ICANS was very low compared to available published data. Any experience in that area intervention or anything can explain why you have this? Though there are a good amount of patients, they have CNS involvement.
Great. So all of patients will be on Kibra as prophylaxis before they get the lymphodepleted chemotherapy. Probably because like grade 1 is like it's need very meticulous يعني observation and يعني decision. It's like if you look to the grading, is like weakness, right? Which could be يعني under recognized in some patients. So probably this is one of the factors.
Thank you very much, Dr. Ibrahim. And now we'll move on to the third talk of the session. It's my pleasure to introduce Prof. Miral Biksash.
Hello, are you able to hear me?
Yes,
thank you. That's welcome, Prof. Miral, to Saudi Society of Blood and Bone Marrow annual meeting. It's my pleasure to introduce you, Prof. Miral Biksash, is currently a professor in Al-Shara Lymph Hospital in Hematology and Stem Cell Transplantation Unit. She was the founding president of Ankara University and related donor registry of blood bank. Her interest in research is focused on immunogenetics and plasma cell disorder. She received her medical and postgraduate training mainly in Ankara, with experience as a visiting scientist or clinician in various institutions over the world, including Sweden and USA. Prof. Biksash is an active member of Turkish Society of Hematology as well as International Hematological Society, like EHA, SSBMT, ASBMT, and others. She is the chairing of myeloma subcommittee, the Turkish Society of Hematology, and she has recently been elected as a board member of European Myeloma Network and the vice chair of the Balkan Myeloma Study Group, and also the Plasma Cell Disorder Subcommittee of ADMT. Prof. Biksash also a member of editorial and board scientific journals and have published many chapters on more than 250 original papers. And last but not least, Prof. Biksash, she is the editor and the author of the famous book Bone Marrow and Transplantation, published at the beginning of 2007, first edition, and also 2014, second edition. Again, welcome, Prof. Miral, and the mic is yours.
Thank you for the kind invitation and also for the kind introduction. It's an honor for me to be here, unfortunately only on the virtual platform. So today I will be trying to summarize within half an hour the autologous stem cell transplantation. Recently, a week ago, we had a meeting, an international training course, and we know very well that autologous stem cell transplant in multiple myeloma is a standard of therapy. And the number of transplants have been stabilized through the years for first transplant and second transplant. But what is more becoming a popular topic is the CAR T therapy in myeloma field, and the numbers are also increasing, which can be seen here. And during this meeting, the majority of autologous stem cell transplant, as you see on the left side, is a well-known factor. And on the right side, Nico Gagelman introduced that the number of CAR T cells in Europe has now increased to 500 now. So based on the standards and the new treatment approaches, is stem cells transplant still the standard of care in myeloma? There are multiple factors that make the decision for stem cell transplant in our patients is the need for high-dose therapy and the timing of the first and also the salvage transplant or tandem transplant. And this relies on the fact that not only the disease, but also the patient-related factors defining the eligibility for transplant. And the other side of the coin is the availability of alternative therapies for stem cell transplant, and that also differs from one country to the other one. There are multiple guidelines, which is widely available, published by SSBMT, different societies such as the British NCCN, and we recently have updated our Turkish myeloma guidelines, and we try to base our evidence on the publications, and mainly the comparative trials are the things that define the guidelines. Through these, it's possible to have a focus on the high-dose melphalan in different following the different induction regimens, and the impact of the newer ones, the novel ones, which are mainly the quadruplets, and also has the standard high-dose melphalan still the valid option. Today, I'm not going to touch upon this. Although we recently have published the role of adding bortezomib into Velcade, it does not really change the efficacy of high-dose melphalan, despite the IFM and the French data conflicting two studies from the French group. And the role of tandem transplants is still questionable. And role of salvage transplant, I'm not going to touch upon this today. And the last topic is the most popular one, which is not finalized yet. So SSBMT, standard data, allogeneic stem cell transplant, although questioned a lot of times, is not generally recommended for multiple myeloma patients, apart from the tandem transplant approach, which can be the second transplant following the autologous stem cell transplant in very young and high-risk patients if, in rare conditions. And in AL amyloidosis, which is not the topic today, it's not recommended either. In the NCCN guidelines, after efficient induction regimen, autologous stem cell transplant is standard, but deferring therapy, the transplant has become an option, and for progression, which can be seen here. And in our current update on the Turkish guideline, I'm sorry, this is in Turkish, and we don't have it in English yet, but we try to have an umbrella type of induction regimens covering all those which are currently approved and will be hopefully approved soon. These, after induction regimens, the main decision-making issue is the response to induction. And we have integrated the deferring type of approach here. And so it is becoming a more and more important topic for rare but very good risk patients. And tandem transplant is an option for our standard as well. What about transplant eligibility? Age is not a determinant, and it's the biological age which matters. And we all know that comorbidities is a very well-known factor for all those people who are experienced in stem cell transplant. The HCT comorbidity index or the comorbidity EBMT index, which combines the EBMT risk score with the comorbidity together, and various frailty assessment tools. These are all possible to define eligibility for transplant, but we have to consider the fact that frailty assessment is not a status quo. It's a dynamic situation, and after an effective and successful induction regimen, and the frailty may change, and the patient who is not eligible at first diagnosis may become eligible. And the most simple performance status, Karnofsky, is still a major tool we have to keep in this mind. I will pass these quickly and go to the next part, which is the role of stem cell transplant. Everybody asks this question: what is the impact of stem cell transplant? What does the high-dose melphalan do to the myeloma disease? Initially, when stem cell transplant was becoming a standard, there were yes or no studies, which was expected. But later on, as stem cell transplant became a accepted modality, then the study designs changed. But now we are now back to yes or no studies again. Here's a summary of the trials which were comparing stem cell transplant versus the non-transplant. If you leave out this study where the comparator arm is a very poor one because it's devoid of the PI. But other than that, this study which we participated in and published has become a very valuable reference for many studies showing the impact of standard first transplant and double transplant, and these two very famous studies which has been presented hundreds of times. And these two, Cardamom and Forte, are the current yes or no studies. The way how to read the IFM study, early versus delayed transplant, it shows that there's a benefit from the transplant with the progression-free survival about 4 years, and this PFS advantage is lost in the overall survival. Here we have to note that the maintenance duration is limited. It's unlike the determination trial, which was performed in the US part, very similar, RVD alone versus stem cell transplant again, but here the maintenance is continuous. And this results with a 20-month prolongation of the progression-free survival. Again, likewise, overall survival impact is lost with stem cell transplant. So deferring transplant does not have a inferior impact on overall survival. And how can we look more carefully on the depth of response after induction and following stem cell transplant? So here in yellow or orange, you see the CR rates. And in this old Spanish study with 6 cycles of VRD, stem cell transplant, and 2 consultation, with each step of therapy, we see a deepening of response. So with VRD as the induction regimen, it is possible to see the deepening of stem cell transplant. How much does stem cell have an impact? The amount of the decrease after the stem cell transplant is higher than the amount that you can achieve with consolidation. But you may say that we have reached such a point that the consolidation, similar drugs given as here, may not have that much impact. But still, it is possible to see the deepening with VRD only. What about if there's another study again from the Spanish group? If you look with a similar approach, post-induction and post-autologous stem cell transplant, just focus on the blue columns, which alludes to the VRD regimen. We see we again observe the deepening of response in terms of VGPR and also MRD negativity. So the Forte and the Cardamom studies. Forte is a very elegant study, just very simple, KRD carfilzomib, lenalidomide dexamethasone, with or without stem cell transplant. And instead of lenalidomide, we have the cyclophosphamide here with stem cell transplant only. And who is the winner? Of course, the winner is KRD plus stem cell transplant. And with KCD, even with stem cell transplant, we don't see that much of a improvement. So stem cell transplant is a major role player, but not as much as the induction or the post-transplant regimens. So transplant should be regarded as not only by itself, but as the previous and post-transplant regimens. In the Cardamom study, again, the same story. With KCD here, KCD without transplant is not able to compete with stem cell transplant, although the difference is not much here. It's going to be changing in future. We wrote a commentary to this publication trying to summarize. I don't want to take your time. You can refer to it in future. And so far we just focused on the triplets. What about the quadruplets? It's here a cross-trial comparison, which we tried to start with VAD regimen and finally with the last quadruplet VRD DARA. And the improvement in VGPR rates in yellow is visible and it's unimaginable. In this era, we would not dream of this type of deep responses. So at a glance, you can compare the three trials, the BDT, DARA, Cassiope regimen. The final results of it has been recently been published in the Lancet Oncology. The Griffin trial, the phase 2 version of Perseus. Perseus is the phase 3, published this year in New England Journal of Medicine, in which trial we have participated, is an EMN study. And the response and the PFS values are approaching 90%. And if we apply the same approach, looking at the post-induction, post-stem cell transplant, and post-consolidation in each study, the trend is the same. The CR rates are increasing in all of these, including the Perseus study, and the continuous part of the maintenance is not the same in the Cassiope, which we need to anti-CD38 is not only DARA, isatuximab can be another agent. In this study, the German study, we only have the MRD rates and VGPR post-induction, and so in future we will be having more data post-stem cell transplant and further on. So post-induction and post-ACD MRD rates is improving from 50 to 66%, which is really a big achievement. Another study recently published, a small study from US, is a isatuximab in combination with carfilzomib. So instead of BRD, we have the KRD, And the post-induction and rates and after the consolidation, the deepening of response is observed. And here the MRD negativities are very similar to the previous study I have mentioned. In high-risk disease, there needs to be another approach which not only combining and using carfilzomib instead of bortezomib, which is the more recent study again from Europe. And the ISKIA study was comparing isatuximab KRD versus KRD alone with only MRD data, which is currently published, and deepening of the MRD rates at different level is a success story. And is this enough? That is the question. And please bear in mind the rates of patients who are with the minus 10/6 level, which is the dark ones, 52% post-ASCT compared to the post-induction and post-consolidation going to 6 to 7, because I will be soon showing you another, but a French study in the high-risk setting again, but using a different approach, adding a tandem transplant. So far we have seen that not only CR rates, but MRD is an important measure. And does this only give us a guidance for measurement of response, or does it have other implications? I think it has, because here what we are saying is in the IFM study, patients who received MRD negativity with or without transplant, they are both doing well, but versus those who could not do that well. Only the fact that with transplant, even the MRD positive patients are doing better. And a similar thing has now been presented with the Perseus study. We see the same observation. MRD negativity, regardless of the treatment, is doing the best. But with the VRD, MRD positivity is better than the other one. So the role of stem cell transplant. It has been questioned by the CTN study. It's an old study which shows that the double transplant did not have a major impact, but this is a kind of an incomer, all-incomer study, so it's very difficult to control. I told and presented earlier the EMN2 study was in favor of the tandem transplant. This has been presented and it's been shown very well that high-risk patients are doing and benefiting from this double transplant more than the standard risk patients. So it's this has been a conclusion, a well-accepted conclusion. And based on this, the concept trial, Isaac KRD in high risk, but with a single transplant, has been followed the same approach using anti-CD38 with a KRD backbone instead of ISA here, DARA. The approach is 6 cycles of DARA KRD, stem cell transplant, again a consolidation, a second transplant, and a continuous DARA-LAN maintenance. This study has been presented at the last ASH meeting, and here we observed the impact of the second transplant and MRD negativity at each step is increasing, and it's approaching to 94%, unlike the ISKIA study. But you may say that the ISKIA study is a early to follow study. It may change in future, but this kind of approach really emphasizes the importance of the quadruplet regimen, the tandem transplant, and continuous therapy. There is a cost for every intensification, and here I wanted to summarize the different quadruplet regimens and trying to show the type of mobilizations at which time point and the mobilization regimens. And it is possible to see that the mobilization failure is a problem, but it's possible to overcome. And in the Griffin study, there was an increase in the plerixafor need, and that need has been doubled in the Perseus study. So there are multiple ongoing studies. What they are trying to do is to compare the maintenance phase and adding DARA to lenalidomide, or another study likewise, and adding the MRD to be able to determine if it is possible to stop at some time point treatment. There are very complicated trials, such as the MIDAS study. When it is finalized, it will give multiple answers, including the tandem transplant, response to induction effect, delaying transplant, and another study from UK, the RADAR study, will also give multiple answers once it's finalized. Topic is the CAR-T. So CAR-T is a tremendous improvement in the field of hematological malignancies, and the reputation is replicating in the multiple plasma cell disorders field as well. Its toxicity is not something deniable, but it's once and a continuous treatment efficacy, which is the brilliant part of it. The CAR-T4 trial, which was a comparison of CAR-T versus standard of care, included patients starting from the first relapse. And the first relapse patients were those who were early relapsing patients. So this is a new entity called the functional high risk. And in this category of patients, the CAR-T was also beneficial. So even in a high-risk group, CAR-T is better than the standard of care. And we recently, in the auspices of EBMT, tried to build a new novel EBMT early relapse score based on very simple parameters, including post-induction response, VGPR or lower, ISS, and Karnofsky score. We were not able to integrate FISH into this, but later during the WBMT group in that platform, we have been now able to validate this, which will be presented at the coming ASH meeting. So please focus on this first 12 months that it's possible to predict ahead of time patients who will have about approaching 50% of relapse risk, early progression risk. So if we identify such patients earlier, maybe those patients can be candidates for CAR-T. This current CAR-T2-6 study, which is ongoing worldwide, will provide the answer comparing autologous stem cell transplant versus a CAR-T approach, and using the quadruplet, which is the most intensive and most efficient induction regimen. So I'm approaching my last slide, and this is I have borrowed from Marie Mateos, and I tried to modify it. The field in myeloma is moving, and earlier we were saying transplant eligible versus non-eligible, but this category has changed now. We have a CAR eligible patient profile appearing, but things are moving fast, as I have tried to explain. In addition to the induction, post-transplant regimens play a major role, and we are now seeing after transplant around 50% of MRD negativity, which is now becoming, almost becoming 100%, and it allows stopping therapy. So it is possible to say that we have to choose patients and also diseases. And this is my new affiliation, my new hospital. And I also would like to advertise our coming meeting. And thank you for listening and for this opportunity. I hope I have been on time.
Thank you very much, Prof, for your elegant presentation and the time now for questions. Can I have the first question? In the era of quadruple therapy, as you mentioned, MRD is very important and it's like independent prognostic marker, probably more important than cytogenetic profile. What's your definition of MRD and how we can apply it in clinical practice?
So thank you. MRD is a very important topic, and it's also very heterogeneous. As you have seen in different trials, and the level of the threshold can be 10 over minus 5 or 6. And the 7 has been tested, but it's a very ambitious goal, only limited to very few referral centers. And earlier it was 10 over minus 4, but it's become that that can only be used as a eligibility criteria. For instance, in the current ongoing study, in the Excalibur study, for instance, the starting point will be minus 10 over 4 is the cutoff. But for a response assessment, all studies will and in future for all centers will be recommended to provide deeper, more sensitive results. And how to achieve this? How can we measure this? For two tools, the next generation flow is more widely applicable. The method is standardized. The NGS-based MRD, and that relies on the diagnosis material, the typing of the clonal proteins, and other than that, there is another tool which is the use of mass-fix. So currently there's a shift now moving to measure the mass spec-based M protein at a sensitive level in the blood, and there's a high correlation. And if peripheral blood mass fix becomes negative, the possibility that a marrow MRD is negative, but it's also possible that it can still be positive because marrow MRD is more sensitive. So there are different tools and different thresholds.
Thank you. Any other question? Yes. Thank you so much for this comprehensive talk. Just wanted to ask, what is the current practice at your institute for patient who's transplant eligible? As you know now, CAR-T, myeloma is still incurable, so a significant number of patients will need immunotherapy such as the CAR-T, and cytopenia is really a complication that we face. If you have a patient who is transplant eligible, are you doing collections for the stem cells to keep some for possible cytopenia after CAR-T? What is the current practice in your institute?
So far in our country, CAR-T has only been limited to a clinical trial, which is for high-risk patients, and it's not in routine practice. It's not approved or reimbursed. But and this is I'm talking on not only limited to myeloma, but also for other disorders as well. But what I would give as an answer based on the experience of others is if you have already stored stem cells, that can be a backup for such a situation. And for lymphocyte harvesting, if you are also referring to is a separate entity for during I do not think any country would go directly without an autologous stem cell transplant to a CAR-T application unless the patient is highly refractory. So that means that autologous stem cell transplant done and then proceeded to CAR-T will may or have you the option of a backup autologous stem cells for such a prolonged cytopenia after CAR-T.
Okay, thank you. Anybody have any other questions? Okay, thank you very much, Prof. Meron. I appreciate your time and your elegant presentation, and welcome again to our SSBMT annual meeting.
Thank you.
Welcome.
Thank you. And I also invite you to come to Istanbul in the beginning of May, and it will be a wonderful opportunity to meet face to face. Thank you. And bye-bye, and have a successful meeting, rest of the meeting.
See you there. Thank you. And now the time for the break and coffee, and then we'll continue our session.
So we shall proceed with our program. It's a pleasure again to welcome you and thank you again for those who are staying till the end of the program. Our next session is a special session, and it marks a new collaboration with the American Society of Transplantation and Cell Therapy, the ASTCT. And as I indicated yesterday in our opening remarks, this meeting this year marks again signing a new MOU with the ASTCT, which has already taken place and signed, launching again a new collaboration with this prestigious scientific entity. Looking forward again to implement this collaboration and to enhance this collaboration in a way that impacts our patient care and general development in science in the hematology and stem cell transplantation and cell therapy. It should impact education in general, research, and all the strategic domains of the SSBMT. I would like to thank President Corey Cutler, who has been engaged and supposed to be with us here physically. However, due to his commitments and hopefully to see him face-to-face in future meetings. And I would like to thank Andre Williams, the Executive Director of the ASTCT, again for his efforts in making this signing and this collaboration happens. I would also like to thank and invite Dr. Shahrukh Hashmi. Dr. Hashmi is the chairman of Siha Oncology Abu Dhabi, United Arab Emirates, who is with us here representing the ASTCT and who signed on behalf of the president of the ASTCT. So again, a pleasure to have him with us, and I would like to invite him to the podium to give his remarks and to chair the next session. Please, Shahrukh.
Well, Dr. Oscar, ladies and gentlemen, thank you very much for having the ASTCT being represented here. I have been in touch with Dr. Corey Cutler, Andre Williams, and Anna for the TCT. The American Society of Transplant and Cellular Therapy believes in collaborations, international collaborations, and really cementing the relationship in order to improve the patient care and research innovation. We signed the contract today. We are very pleased on behalf of the American Society for Transplantation Cell Therapy. We welcome a partner, SSBMT, with us, and hopefully we're going to be working together in research projects, but immediately we will be having you as a member of our international committee of ASTCT, and looking forward to see all of you at our annual meeting in February in Honolulu, Hawaii, at the ASTCT Tandem meeting. Thank you very much. Having said this, and being really excited about this new venture, ASTCT SSBMT collaboration, our next session is called the ASTCT session. It's on very cutting-edge therapies. I'm going to move there actually and introduce our 3 cutting-edge speakers for this. And before I go there, once again, we thank SSBMT, we thank Dr. Oscar, we thank all of you for inviting us and collaborating with us for the ASTCT SSBMT collaboration. Thank you very much. session, we've got three wonderful speakers. The first session is recorded, and then we've got live virtual sessions. It's a great pleasure for me to introduce, for the first talk, Dr. Perla, who's Associate Professor and Director of the Phase 1 program, and Associate Chief of Clinical Research, Division of Hematology and Hematologic Malignancies, Department of Medicine at Huntsman Cancer Institute in Salt Lake City, Utah. Thank you very much, Dr. Perla, and please go ahead and show the video of his presentation.
The members of the organizing committee for giving me this opportunity to present the topic. I am Narayani Perla from the Huntsman Cancer Institute at the University of Utah, and I am delighted to present the ASTCT clinical practice recommendations for transplantation and cellular therapies in diffuse large B-cell lymphoma. These are my disclosures. Autologous hematopoietic cell transplantation has long been the standard approach for patients with relapsed or refractory chemosensitive diffuse large B-cell lymphoma. However, the advent of CAR T-cell therapy has caused a paradigm shift in the management of relapsed refractory DLBCL patients, especially with the recent approval of CD19-directed CAR T-cell therapies in the second-line setting in high-risk groups, that is, primary refractory and early relapse DLBCL. Allogeneic transplantation is another potentially curative option in relapsed or refractory DLBCL that can provide durable disease control even after autologous transplant relapse, with a therapeutic mechanism attributed mainly to the graft versus lymphoma effect. The use of reduced intensity conditioning with allogeneic transplantation has significantly expanded the access to allogeneic transplantation across the world. However, similar to autologous transplantation, the advent of CAR T-cell therapy has led to a recent decline in allogeneic transplantations, effectively relegating allos for patients whose DLBCL progresses after CAR T-cell therapy. Consensus on the contemporary role, optimal timing, and sequencing of transplantation and cellular therapies in DLBCL is lacking. Hence, the ASTCT undertook this project to formulate consensus recommendations to address this unmet need. We used RAND modified Delphi methodology, which was used to generate consensus statements addressing the sequencing, timing, and role of transplantation and CAR T-cell therapies in patients with both newly diagnosed and relapsed refractory DLBCL. In the Delphi method, participants rate the statements anonymously in generally 2 rounds of voting. In the modified version of the method, a face-to-face meeting with the presentation of the results precedes the second round of voting if needed. Just to give you a snapshot of the various steps. As an initial step, a panel is selected, and for this project, there were 25 physicians that were selected, including 7 members of the steering committee and a methodological expert with expertise in systematic reviews, meta-analysis, and the RAND modified Delphi method. After that, a survey was sent to understand the baseline demographics and scope of the project, which led to the creation of the consensus statements. These consensus statements were then circulated to the panel members, and they provided their voting. A formal consensus what to be achieved if 75% or higher of the panel members voted to agree on the particular consensus statement. If a formal consensus was not achieved, then a second voting survey would be done. Grading of recommendations was based on the Agency of Healthcare Research and Quality, AHRQ in short, based on the level of evidence. Grade A stands for if there is good research-based evidence to support the recommendation. Grade B, when there is fair research-based evidence to support the recommendation. Grade C, the recommendation is based on expert opinion and panel consensus. And grade X, if there is evidence of harm from this intervention. The consensus statements for transplantation and CAR-T treatments in DLBCL were broadly categorized into three groups. After first-line chemoimmunotherapy, in primary refractory and early relapse DLBCL, and late relapse DLBCL. Let's go one by one. First, we'll talk about the consensus statements for transplantation and CAR-T following first-line chemoimmunotherapy in DLBCL. This table and all the subsequent tables will have the same format, has three columns. The first column outlines the consensus statements. The second column outlines the grading of recommendation based on the AHRQ guidelines that we just discussed a moment ago. And the third column depicts the percentage of panelists in agreement. Just to remind the audience, a formal consensus were to be achieved if 75% or higher of the panelists were in agreement. Let's go on to the statements one by one. The panel does not recommend autologous transplantation in DLBCL regardless of the International Prognostic Index score as consolidation in complete remission after first line, that is R-CHOP or similar therapy. The panel does not recommend autologous transplantation in high-grade B-cell lymphoma with MYC, BCL2 and or BCL6 rearrangements as consolidation therapy in PET negative complete remission after dose adjusted R-EPOCH or similar high intensity regimens. Autologous transplantation may be considered in eligible patients with high-grade B-cell lymphoma with MYC, BCL2 and or BCL6 rearrangement as a consolidation therapy in PET negative complete remission after first-line R-CHOP or similar therapy. This is based in part on findings from the retrospective analysis by Landsberg and colleagues suggesting that autologous transplantation as a consolidation can provide a benefit in patients treated with R-CHOP, but not in patients receiving more intensive induction therapies should they achieve CR. The panel does not recommend CAR T-cell therapy in the frontline setting for high-risk DLBCL regardless of the IPI score or presence of MYC, BCL2 or BCL6 gene rearrangements outside the setting of a clinical trial currently. Autologous transplantation may be considered for eligible patients with DLBCL with secondary CNS involvement at diagnosis, achieving complete remission and with undetectable CNS disease after first-line therapy. It is important to acknowledge that this is a data-free area of clinical practice and that this recommendation reflects the expert opinion of panel members as noted by the grading of recommendation of C. The panel recommends consolidation with autologous transplantation for eligible primary central nervous system lymphoma patients in first complete remission. The panel recommends thiotepa-based conditioning regimens when using autologous transplantation as a consolidation for eligible primary CNS lymphoma patients in first complete remission. Let's move on to the second broad category of consensus statements for transplantation and CAR T treatments in primary refractory and early relapse DLBCL. Of note, the early relapse is defined as relapse within 12 months of first-line chemoimmunotherapy. The panel recommends CAR T-cell therapy as standard of care option in patients with DLBCL who have refractory disease to first-line chemoimmunotherapy or have relapsed within 12 months of first-line chemoimmunotherapy. This is based on the high-level data from 2 phase 3 randomized trials that showed superior event-free survival, and more recently, one of the trials showed overall survival benefit on long-term follow-up in patients with primary refractory and early relapse DLBCL receiving CAR T therapy compared to standard of care salvage therapy. For DLBCL patients with early treatment failure but established disease responsiveness to salvage treatments, careful consideration of the pros and cons of CAR T-cell therapy versus autologous transplantation as a consolidation is warranted. It has been previously shown that patients achieving chemoresponsive disease to salvage therapy may experience durable remission following autologous transplantation, including those with early chemoimmunotherapy failure. In studies comparing standard salvage chemotherapy with autologous transplantation versus CAR T-cell therapy in the second-line setting in the phase 3 randomized trials in relapsed refractory DLBCL, only a small portion of patients in the standard of care arm underwent autologous transplantation compared to those who received CAR T-cell therapy in the experimental arm. In addition, the data on chemosensitivity prior to autologous transplantation was reported only in one study, that was Belinda, wherein 31% of patients achieved chemosensitivity prior to autologous transplantation. Although CAR T-cell therapy provides superior outcomes relative to standard salvage therapy in the second-line setting, the most appropriate strategy, that is, autologous transplantation versus CAR T-cell therapy in patients with relapsed refractory DLBCL achieving chemosensitivity, was not determined in these trials. In a recent CIBMTR analysis by Shadman and colleagues, the authors found that autologous transplantation was associated with a lower incidence of relapse and superior overall survival compared with CAR T-cell therapy in patients achieving a partial remission after salvage therapy. Of note, this was not an intention to treat analysis, but rather an analysis of patients who had infused cells. And the authors acknowledged this as a potential reporting bias, rightfully. Keeping this data in perspective, for patients with relapsed or refractory DLBCL achieving chemo-responsive disease, that is either CR or PR, to salvage therapy, the panel considers autologous transplantation as an acceptable therapeutic option in eligible patients as depicted by grade B, which is the consensus statements 2 and 3 on the table. In DLBCL patients with early relapse who achieve a complete remission or partial remission to salvage therapy, the panel considers CAR T therapy as an acceptable therapeutic option. Moving on to the last broad category of consensus statements for transplantation and CAR T treatments for late relapse DLBCL. Again, late relapse is defined as relapse beyond 12 months of first-line chemoimmunotherapy. In DLBCL patients, the standard of care in the relapsed or refractory setting has been autologous transplantation in those who achieved a chemoresponsive state, either CR or PR, based on the results of the pivotal PARMA study that compared autologous transplantation with further cycles of salvage chemotherapy in patients achieving a response after the initial salvage attempt. These results were further corroborated in the rituximab era in the CORAL study. Furthermore, patients who achieve a CR to salvage therapy, especially those with a negative post-salvage PET, that is PET CR, have the best outcomes after autologous transplantation. That is 3-year PFS of over 80% with PET CR versus less than or equal to 35% with positive PET. These data underscore the role of autologous transplantation as a consolidation in relapsed or refractory DLBCL patients achieving a response, either CR or PR to salvage therapy. Hence, based on this data, in DLBCL patients with late relapse, the panel recommends autologous transplantation as a consolidation therapy in eligible patients who have achieved a complete or partial remission after second-line therapy. In the SCHOLAR-1 study, the CR rate was 7% and the median overall survival was 6.3 months with the use of existing therapies in patients who had aggressive B-cell non-Hodgkin lymphoma that was resistant to chemotherapy or who experienced a relapse within 12 months after autologous transplantation. In contrast, results from 3 single-arm phase 2 pivotal CAR T trials, ZUMA-1, Juliet, and Transcend, which established its utility in patients with multiply relapsed DLBCL, showed relatively better outcomes with CAR T-cell therapy in these settings. All 3 CAR T-cell products demonstrated the ability to induce durable remissions in approximately 1/3 of treated patients, including those not achieving a durable remission with a prior autologous transplantation, thereby receiving US FDA approval for treating relapsed or refractory DLBCL patients after at least 2 prior lines of therapy. The recently published 5-year follow-up analysis of ZUMA-1 continues to demonstrate sustained overall survival and disease-specific survival in these patients. Hence, based on this data, in DLBCL patients with late relapse, the panel recommends CAR T-cell therapy in patients who have not achieved remission, that is, have not achieved either CR or PR to second-line therapies. In patients with DLBCL, the panel recommends CAR T-cell therapy in patients who are not eligible for autologous transplantations due to comorbidities or age, regardless of the timing of relapse. In patients with DLBCL, the panel recommends CAR T-cell therapy who have relapsed or refractory after 2 or more lines of systemic therapy. The panel does not consider secondary CNS involvement as a contraindication for administering CAR T-cell therapy. In relapsed DLBCL patients with available access to CAR T-cell therapy, the panel recommends offering CAR T-cell therapy before proceeding with allogeneic transplantation. Allogeneic transplantation may be necessary for patients who relapse after CAR T-cell therapy, given that allogeneic transplant can be potentially curative following failure of autologous transplant, especially in patients who achieve chemosensitivity. In the CAPM analysis of a little over 500 patients with DLBCL who relapsed after autologous transplantation and underwent subsequent allogeneic transplantation, 31% were able to achieve long-term PFS at 3 years. In a recent multi-center retrospective study of allogeneic transplantation following CAR-T failure, the 1-year PFS and OS rates were 45% and 59% respectively. In both these studies, the single factor associated with superior outcomes was achieving chemosensitivity at the time of allogeneic transplantation. Hence, the panel recommends allogeneic transplantation in eligible DLBCL patients relapsing or progressing after CAR T-cell therapy if they achieve a complete or partial remission with subsequent anti-lymphoma therapies. The panel recommends allogeneic transplantation eligible relapsed or refractory DLBCL patients after autologous transplantation failure in regions without access to CAR T-cell therapy and in those with CAR T-cell manufacturing failure, ideally after achieving a complete or partial remission with subsequent anti-lymphoma therapies. The panel recommends reduced intensity conditioning or non-myeloablative conditioning regimens for eligible patients undergoing allogeneic transplantation. In clinical scenarios where data from prospective studies are either scarce or unavailable, or in situations in which patient populations included in the published trials are less relevant to contemporary clinical practice, formal consensus recommendations can be invaluable resource to inform clinical decision making. The advent of bispecific antibodies will imminently further change the therapeutic landscape of relapsed refractory DLBCL. CAR-T and bispecific antibody therapies are now being studied in the first-line treatment, and treatment algorithms will continue to evolve as data emerges from these studies. So stay tuned for additional changes in the coming years. I would like to thank everyone for their undivided attention and would like to acknowledge the Committee on Practice Guidelines, Dr. Carpenter and Dr. Hamadani, the steering committee members, Dr. Suter, Dr. Miguel Perales, Dr. Kharfan Dabaja, and Dr. Locke, expert statistician, Dr. Kumar, and all the panel members outlined on this slide. Thank you. Hello, everyone.
Well, thank you, Dr. Perla. Thank you for being live. We have the question and answer sessions after the next speakers. A couple of them are also live from US. So stay tuned. We'll be getting back to you in a little bit right after the talks of Dr. Paj and Dr. Pagul. Thank you so much. And we realize very early in the morning in US, especially Utah time. The next speaker is live as well from US, Dr. Haider Frango, who's going to talk about gene addition and gene editing and gene addition therapy for hemoglobinopathies. Dr. Frango is a board-certified physician in pediatric hemonc, investigator Sarah Cannon, research and treatment of blood disorders for pediatric and adult patients, and specialized in BMT. He has served as medical director of pediatric hemonc for Sarah Cannon at the Children's Hospital TriStar since 2015, internationally recognized for his research and expertise in stem cell transplantation, is bilingual and speaks Arabic as well. Without any ado, Dr. Frango, please go ahead. Thank you so much for being with us.
Thank you for having me. I just want to confirm that you can hear me.
We can, yes.
Perfect. Well, thank you so much for the introduction, and thank you so much for the invitation to participate in this meeting and talk a little bit about our work that we have done over the last a few years. And good morning from Nashville, Tennessee, and I know it's in the afternoon in Saudi Arabia. First, I'm going to give a quick introduction on AIDS. Sickle cell disease is a devastating disease that involves multiple organs, including the CNS, the lung, the bones, skin. It is related to chronic hemolysis as well as vaso-occlusive crisis that can cause devastating complications in individuals with sickle cell disease. In fact, recent studies have shown in the United States that the median survival for individuals with sickle cell disease is around 46 years, which is much lower and much worse than the general population. And that's related to the chronic damage to the organs. Beta thalassemia, on the other hand, is a disease of red blood cell production where there is a mutation in the beta globin gene where either you make some beta globin or no beta globin, and that results in severe anemia in early childhood requiring red blood cell transfusions. And the red blood cell transfusion can cause a significant damage to the heart, lung, and endocrine. And patients with beta thalassemia require chronic anti-iron or iron removal therapy with chelation. And despite that, there is significant end organ dysfunction related to iron overload. Patients also can experience high risk of thrombosis, especially in those who are splenectomized. The only curative therapy for individuals with sickle cell disease and beta thalassemia is allogeneic bone marrow transplantation from a matched sibling. Unfortunately, only around 18% of patients have a matched sibling that's not affected. So that basically leaves around 80% of the patients with no potentially curative option. So why gene therapy as an appealing option? Because it uses autologous cells that are modified and reinfused into the patient. There are two general approaches for gene therapy for sickle cell and beta thalassemia. One is a gene addition approach, and one is a gene editing approach, which I'm going to concentrate on talking today because of the lack of time. I'm going to limit my talk to the gene editing approach that we have done over the last 5 years as a multi-center trial. So we will go into details in this in just a minute, but I just wanted to mention that autologous transplantation allows this therapy to reach every patient with a disease. So just to go to some basics, in the main hemoglobin in early life is fetal hemoglobin, and fetal hemoglobin is made of 2 alphas and 2 gamma globin genes. So what happens is 2 alphas and 2 gammas form fetal hemoglobin, and fetal hemoglobin can be protective for babies until they are born. And after birth, there is a drop in gamma globin production and increase in the beta globin production, causing the patients to develop the manifestation of the disease. So individuals with sickle cell disease, when the beta globin gene starts getting produced, it is mutated and cause manifestation of the disease. And individuals with beta thalassemia, because they cannot make beta globin, they become transfusion dependent anywhere between 3 to 9 months of age. And that's because of the change between the gamma disappearing and the beta globin being produced. There was an early observation published in New England Journal of Medicine in 1994 by Ora Platt following around 3,700 patients with sickle cell disease for several decades. And the interesting graph in this paper that was published again several decades ago was that the individuals with a persistent fetal hemoglobin of over 8.6% have almost double the survival at 50 years of age compared to those who do not have an increase or persistence in the fetal hemoglobin. Multiple papers since that time, and I'm not going to go into it, have shown that persistence of fetal hemoglobin can be protective in both individuals with sickle cell disease as well as those with beta thalassemia. This is a graphic representation showing that individuals with sickle cell disease here on the left, when they achieve a fetal hemoglobin of around 20 to 30%, they have either mild disease manifestation, or when they reach around 30% fetal hemoglobin, they become totally asymptomatic. Similarly, in individuals with beta thalassemia that have persistent fetal hemoglobin, the higher the fetal hemoglobin, the lower the need for transfusion therapy and the less the morbidity is. So there are naturally occurring polymorphisms that occur in some individuals with sickle cell disease and beta thalassemia that result in persistence of fetal hemoglobin and allow those individuals to either not experience any complications with sickle cell disease or have significantly reduced transfusion requirement in the beta thalassemia patients. So what we have used in our studies is something called CRISPR-Cas9 to achieve editing of the BCL11A gene. So the BCL11A gene suppresses the production of the gamma globin. So think about it as the brakes that stop the babies after they are born from making gamma globin. And what we have achieved is actually causing a break in the DNA in the erythroid enhancer region of the BCL11A gene, resulting in reactivation of the gamma globin expression and thus increasing the levels of fetal hemoglobin. The drug I'm going to talk about today is CTX001, which is produced by an ex vivo editing of the erythroid enhancer region of the BCL11A gene in CD34 hematopoietic and progenitor cells, resulting in elevated fetal hemoglobin and in the erythroids. So what are the patient journey? I'm going to start with the beta thalassemia trial that was initiated in 2018, and it is the CLIMB 111 trial. It's an international phase 3 trial that is enrolling patients who are 12 to 35 years of age with either a beta 0 genotype or beta 0 beta plus with a excuse me, with a transfusion requirement of either more than 100 mLs per kilogram or more than 10 units of red blood cells per year. And the primary endpoint of this trial was being transfusion independent for 12 consecutive months while maintaining a hemoglobin of greater than 9 grams per deciliter. And we know that this trial met its primary and secondary key endpoints and demonstrated a favorable benefit-risk profile, resulting in approval of this therapy in multiple regions in the world, in the United States, United Kingdom, European Union, and the Kingdom of Saudi Arabia and Bahrain. So I'm going to show the results of this trial. Just briefly to go over the patient journey, the patients usually are screened, and then if they are eligible, they undergo peripheral blood stem cell collection using GCSF and plerixafor. The stem cells are then gene edited and then shipped back to the transplant center, where patients undergo myeloablative busulfan conditioning over 4 days that is pharmacokinetically adjusted, and the cells are infused, and the patient is followed for 2 years for engraftment and transfusion independence. Then the patients are enrolled on the long-term study for 13 years to evaluate safety and efficacy. So this is the full data analysis here, which included 56 patients. The mean age was 21 years of age. And I want to point out that 35% of the patients were adolescent between the ages of 12 and 18, and they were equally divided between male and female. But I want to just point out that more than half the patient had severe genotype with either beta 0 or beta 0 like mutation, and 37% of the patient had a non-beta 0 like genotype. The historic red blood cell transfusion were 37 units per year, which is, as you know, is quite a large amount of red cell transfusion. The difference between the full analysis set and the efficacy set is that the full analysis set includes all the patients, while the efficacy set includes patients with enough follow-up to be evaluated for 12 consecutive months. So the number of mobilization, the mean number of mobilization was 1, ranging from 1 to 4. The XSL dose was 8.4 million CD34 per kilogram, ranging from 3 to 19 million. And the duration of follow-up was 32 months, which is almost 3 years. All patients engrafted neutrophils and platelets at a median of 29 and 43 days, respectively. And it is important to point out the duration of neutropenia post-infusion of XSL was around 20 days, and the time to the discharge to the hospital was 39 days. So I'm just going to orient you on this what we call swim plot. The area here on the left that I'm pointing out to includes the time prior to the transplant and XSL infusion, and each diamond dot represent a red blood cell transfusion. The area that is in red is the time when the patients are receiving red cell transfusion. The dark gray area is a 60-day washout, which we allowed to do that prior to starting follow-up. And then we count the primary efficacy endpoint is 12 months following this washout period. So 49 of 52 evaluable participants achieved the primary endpoint and became transfusion independent. Basically, 94% of the patient, this therapy made them transfusion independent. There were 3 patients. 2 of those actually have discontinued transfusions, and you can see them here. And 1 participant discontinued transfusion, now being transfusion independent for 21 months, and another individual is transfusion independent at 14 months. And 1 participant stopped red blood cell transfusion and went 10 months without a transfusion, and then developed a viral infection, required transfusion, but now is at latest follow-up, the patient is also transfusion independent. I did not go into the data using allogeneic transplant for beta thalassemia, but this data compares very favorably to what we see in individuals that undergo HLA-matched donor transplant for beta thalassemia. Basically, although there were 3 patients that were late becoming transfusion independent, now every patient is not receiving any blood transfusion. The data was similar between those who are adults in the top panel here, as well as the adolescent cohort. It's 94% in each cohort. So it was similar in adults as well as pediatric patients. This graph here shows the participants, all participants with the total hemoglobin and fetal hemoglobin. And here the plot on the right is divided between individuals who are adolescent and adults. But what I want to point out here is that everybody has normal hemoglobin, with the majority of the hemoglobin being contributed to by fetal hemoglobin. When we look at the red blood cells, the distribution of the fetal hemoglobin is pancellular, with no more than 95% of the red blood cells containing fetal hemoglobin. And we evaluated gene editing in the blood and the bone marrow. The panel below is the blood, and the panel above is in the bone marrow, to evaluate the sustainability and of the editing in the blood and marrow. And as you can see, this is a straight line. There is really no drop off in editing, meaning that the therapy we are using is quite durable. And when you look at the ferritin in patients, the ferritin rises very sharply at month 1 because of the inflammation post-transplant. But 40% of the patients have been able to stop iron removal therapy after transplantation, and none of those patients resumed chelation therapy. And iron removal therapy in those patients consisted of either chelation and or phlebotomy. We presented some data recently at EHA showing that the quality of life in patients actually improved. And I'm not going to go into this detail because of lack of time, but I can reassure you that our data showed that there was a clinically meaningful improvement in quality of life in patients with beta thalassemia. And the side effect of this therapy is what you expect with an autologous transplant with high-dose chemotherapy. The table here on the right describes complications that happened in more than 50% of the patients. And as you can see, febrile neutropenia, mucositis, thrombocytopenia and anemia, nausea and vomiting happened in many patients. And I just want to mention 2 SAEs, a serious adverse reaction related to exa-cel. One was a delayed neutrophil engraftment, and the patient eventually engrafted. And 1 patient who developed HLH requiring immune suppression, and that's also resolved with immune therapy. And now the patient is doing well off all medications. So I just want to mention that the side effects are really truly what you expect with an autologous transplantation. So in conclusion, for the beta thalassemia, that 94% of the patients achieved transfusion independence, and this is durable up to 5 years. And there was a durable increase in total hemoglobin and to near or normal levels, and sustained durable editing in the blood. And this exa-cel has the potential to provide a one-time functional cure for individuals with beta thalassemia. Now, moving to sickle cell disease, the only difference in the patient journey with sickle cell disease is we cannot mobilize patients with GCSF, so the mobilization was done with plerixafor only. And the other thing about patients with sickle cell disease that underwent chronic transfusion or exchange transfusion for 2 to 3 months, prior to collecting stem cells. Again, this was a global international phase 3 study. The inclusion criteria were patients between 12 and 35 years of age. Those who were eligible were those with at least 2 vaso-occlusive crises per year in the last 2 years, basically 2 per year at minimum. And the primary endpoint was how many individuals can go VOC free for 12 consecutive months. We call this VF12. And the secondary endpoint is how many patients are prevented from being hospitalized related to VOC for more than 12 consecutive months, and that was called HF12. Again, this data showed that the therapy actually works, and that supported the approval again in the United States, the European Union, the United Kingdom, the Kingdom of Saudi Arabia, and Bahrain, and this therapy is now commercially available. So just to go over the data here, the full data set included 46 patients. The mean age was 21 years of age. A third of the patients were also adolescent, between 12 and 18 years of age, equally divided between male and female. 89% had beta S genotype, but there were few patients with beta S beta 0 or beta S beta plus. And more importantly, at least 40% of the patients have either 1 alpha gene deletion or 2 alpha gene deletion, which is very common in individuals with sickle cell disease. And the number of VOCs were 4.2 average, and the number of hospitalizations were around 3 per year in the 2 prior years prior to treatment. The number of mobilizations were a little bit more than what we observed with the thalassemia, which was a median of 2 collection cycles, and that's related to the fact that we can't use GCSF. The CD34 cell dose was 4.7 million per kilogram, and the follow-up was around 28 months mean follow-up. All patients engrafted neutrophils and platelets at a median of 27 and 34 days. And I want to point out that the duration of neutropenia following transplant was only 17 days. And the median time to discontinuing red cell transfusion was 19 days, and the hospital stay was around 31 days. Again, this is a swim plot describing each individual patient. The area here in the light gray on the left shows the 2 years prior to enrollment, and each dot represent a vaso-occlusive crisis. The red, dark red area here represent the time the patients were receiving red blood cell support, and the dark gray area represent the 60-day washout, and the green is the follow-up. And 36 out of 39 patients, or 92%, achieved a vaso-occlusive 12 consecutive months of vaso-occlusive free, achieving the primary endpoint of VF12. 7 patients do not have enough follow-up to be evaluable, and 5 participants are remained eligible to achieve a VF12. And it is important to remind you that some of the reasons why patients actually developed vaso-occlusive crisis after infusion of exa-cel included infection with parvo B19 infection, flu, or COVID, procedures including bone marrow, and use of steroids. All participants achieved a durable fetal hemoglobin levels, as I'm going to show you in a minute, of over 40%, and stable allelic editing, despite the fact if they had vaso-occlusive crisis afterwards or not. But again, the efficacy was more than 90%. This here shows the adult versus adolescent, and I don't want to go into details, but both are very similar. 26 out of 28 evaluable adults achieved the VF12, and 90% achieved VF12 in the adolescent cohort. This here describes the secondary endpoint of hospitalization. Again, this is a swim plot with the left side here describing the hospitalizations pre, and 97% of the patients remained hospital-free after treatment with exa-cel, which is quite impressive. When you look at the fetal hemoglobin percent, again, the light blue is adult and the dark black is adolescent. And as you can see, the fetal hemoglobin increased very quickly and was sustained over time at or above 40%. Here also, the patients have either normal or near normal total hemoglobin, as well as achieving a fetal hemoglobin of around 6 grams. Again, the mean hemoglobin in adolescents was 13 grams, which is normal at 12 months, and 13.2 at 24 months. And the median hemoglobin in adults was 12.7 and 13.2 at month 24. We also wanted to make sure that our editing is pancellular, and we evaluated red blood cells, and more than 95% of the red blood cells contained fetal hemoglobin. Basically, this observation confirms that the therapy is pancellular. We looked at bone marrow on the top and peripheral blood in the bottom, allelic editing, and what we found that this allelic editing in the blood and the bone marrow is very stable over time, and that basically speaks to the durability of this therapy. Hemolysis is a huge factor in sickle cell disease. Mechanism of causing complications, and intravascular hemolysis improved in both using a measurement with LDH and haptoglobin. As you see, haptoglobin was undetectable in all the patients initially. It rose at month 1 because it's an acute phase reactant, and was either normal or near normal levels sustained over time. Similarly, LDH was high and it normalized over time. The reticulocyte count as well as indirect bilirubin both improved over time. We have performed quality of life evaluation for patients following therapy, and what we have found that the quality of life improved, and this is very important. We see this in our clinics every day. I'm not going to go into the data in details, but I can tell you that all assessment of general health, physical, emotional, social, and functional well-being were all improved after axi-cel therapy. Not only we improved fetal hemoglobin, but we actually improved the quality of life of patients. The side effects, again, I'm going to go over them, again, related to autologous transplant. The majority of the patients developed fever, neutropenia, stomatitis, vomiting, and diarrhea. I just want to mention that there was one adverse event of unfortunate death following axi-cel, and that was related to a death related to COVID-19 infection. I just want to remind everybody that this study was performed in a time when we were going through the pandemic, the COVID-19 pandemic, and one patient passed away related to complications of COVID-19 infection. So in conclusion, axi-cel is the first and only approved CRISPR-Cas9 gene editing therapy. More than 90% of the patients remained VOC-free, and more than 90% of the patients were able to avoid hospitalizations. We achieved increased and durable fetal hemoglobin of around 40%. There was stable allelic editing in the bone marrow and peripheral blood. We actually improved the quality of life in patients, and the hemolysis markers improved. And the efficacy was equivalent in both adolescent and adults. axi-cel has the potential to be a one-time functional cure for patients with sickle cell disease. I just want to show here a quick example. This is a smear on one of our patients that came in to us to be enrolled on the trial at our center. As you can see here, all of these red blood cells that are deformed and elongated, showing sickle hemoglobin. This is the same patient at 1 year post axi-cel, showing that we do not see any sickled red blood cells in the blood. I want to thank the patients, the centers that participated in this, and more importantly, the pioneers, which I call the patients are pioneers here, because they are the ones that agreed to participate in this first-in-human clinical trial. This is Victoria Gray, which was our first patient that enrolled on this trial. This trial also would not have been possible in our site without a great team we have that was able to work on these studies for the last 5+ years. Here is our team celebrating our 40th infusion of a gene-edited stem cells to treat beta thalassemia and sickle cell disease. Again, thank you for your attention. I'm happy to take any questions at the end.
Well, thank you very much, Dr. Franco. This is an amazing talk, and we will have one last session, and then we'll get you back for the discussion. I think discussion is becoming extremely interesting with the 2 talks, and the 3rd talk is going to be even more. So it gives me a great pleasure to introduce Dr. Neil Butt, who I've known for quite some time, is assistant professor, the Clinical Research Division of Fred Hutch in Seattle, Washington, and in Department of Pediatrics, Washington School of Medicine, Seattle. And Neil is going to talk about the international recommendations for screening and preventative practices for long-term survivors of transplant cell therapy, a 2023 update. Thank you so much. Please go ahead. Thank you.
Thank you very much for inviting me. Let me go ahead and share my slides.
And we can hear you perfectly, Neil. Go ahead.
Okay, great. Are the slides visible?
Yes.
Okay. Thank you again for the invitation to present this topic at the meeting. I don't have any conflicts to disclose. So this is the agenda of the talk today. I will briefly discuss the history of transplant survivorship guidelines and then discuss how we updated the guidelines this time. Then we will also talk about the summary of major changes and updates that we made in this new version, and then talk about the next steps that we are planning. So first, talking about the previous versions of the guidelines. So the first guidelines were published in 2006. This was a publication in ASTCT, in TCT journal, and it was a collaboration between CIBMTR, ASBMT, and EBMT at that time. Subsequently, the guidelines were revised in 2012, and at that time, additional societies had also been involved, including APBMT, ANZTCT, EMBMT, and SBTMO. There were several strengths of the previous versions of the guidelines. There was one table that was specifically very comprehensive and included compact and high yield recommendations for major organ systems. And it was ensured to be feasible across multiple medical systems. There was also additional background provided in the guidelines in a narrative format. As I mentioned, that there were several medical societies that were involved in this effort. So there were contributions and agreements from all of those societies. It is considered a standard of care, and it serves as a foundation and follow-up plan for most of the survivors to this date. And as I mentioned, it was considered standard of care at that time. But it is important to know that a lot has changed since 2012 when the last guidelines were published. As we all know that now annual number of transplants are continuously increasing. So this just shows the number of transplants reported by the CIBMTR, number of allo and auto transplants. And I have highlighted the 2012 year by a red line. And as you can see, the numbers are continuously increasing even beyond that. Additionally, we have changed the way we practice transplant. So specifically with regards to patient age. So on the chart on the left, you can see that the percentage of patients receiving transplant after ages of 65 has significantly increased over the course. And additionally, the donor types use is also changing over time. So the figure on the right shows that the percentage of haploidentical donor transplant is also significantly increased over time. Additionally, we are offering new treatment modalities to our patient population. So this is the chimeric antigen receptor T cell infusions in the US reported to the CIBMTR. And as you can see, since 2016, the numbers have significantly increased, and they continue to go up with increasing indications for CAR T cell therapy. Additionally, we are also doing better at curing patients, and patients are surviving long term. So this paper is from Dr. Navneet Majhel's, and it shows the projected number of survivors of transplant over the time. And on the left, it shows that it is estimated by 2030 there will be 500,000 transplant survivors of all ages. And the graph on the right shows that there will be almost 50,000 survivors of just pediatric transplant by year 2030 as well. As we continue to do better with treating our patients, we are also interested in sharing our information, how the patients are doing long term. So this is just a search from PubMed on transplant and late effects. And as you can see, there were not many publications before the year 2012, which is highlighted by the red arrow. But the number of publications have again significantly increased since 2012. And that is also one of the reasons we wanted to make sure we are capturing additional new data that might be available while updating the guidelines. So with those goals in mind, we pursued this updating the guideline. So this time we took a slightly different approach. We wanted to use this NCCN-like approach. There is a NCCN guideline that are widely used for different cancer populations. And for those guidelines, they ask all the group members to vote on one if they agree with the recommendation, and if not, what would they suggest as a change. And this is how the strength of each recommendation is measured with grade 1, 2A, 2B, and 3. So we used that format, and we went through the several phases of guideline development and revision, as you can see here on the right. And we are finally at the last stage, which is the dissemination of the guidelines. This was again a very large collaborative effort with 31 members representing 11 international societies that include adult, pediatric, and societies and patient advocates as well, as listed here. And these are the names of all the members that participated in this effort. Dr. Seth Rotz and Dr. Rachel Phelan and myself, we took the lead on this effort, and we were supported by senior mentors such as Dr. Betty Hamilton, Dr. Scott Baker, Dr. Christy Duncan, and Dr. Navneet Majhel. It was a co-publication between TCT Journal and EBMT Journal back in February. So I would definitely recommend you to review this publication. I will highlight in next few slides what are the major changes in this guidelines. This is by no means going to be a comprehensive review because it is impossible to go through this entire publication in 25 minutes. But I'm hoping that at least if I can orient you, you can go and review the article and it will be more useful. So in terms of changes in the manuscript, so we added a new hematopoietic complication section which wasn't available before. We did significant expansion of psychosocial adjustment, cognitive dysfunction, and quality of life recommendations. We also updated vaccine guidelines since there is a lot that has changed since 2012. We also added information on return to work and school and other transition resource. We also provided additional recommendation on subsequent malignant neoplasm screening. And then lastly, we included special populations such as or patients undergoing transplant for autoimmune diseases, hemoglobinopathies, bone marrow failures, inborn error of immunity, enzymopathies, metabolic disorder, and myeloma and amyloid diseases, since these patients have their unique needs that we need to address through the guidelines. And additionally, we also highlighted specific considerations for patients who are infants or adolescent and young adults and older adults. So now I'm going to show you some major changes in how we develop those. So this is just a comparison of the topics that were included in 2012 versus 2023. So there are 16 major organ systems included and 20 total topics. Those highlighted in red were not included in the previous version, and the ones in blue are the ones that we have updated. So I'll share some of the examples in next few slides. There were 11 summary tables total for each organ system, and it includes recommendations, evidence grade, references, and comments. We also have several supplemental tables at the end for additional details. And then there are also several appendices for resources for patients and then other stakeholders, and also resources for return to work or school. And I will talk about each of these organ systems one by one. So first I'll talk about the hematopoietic system. As I mentioned, it's a new section, and we specifically addressed autoimmune cytopenia after transplant, clonal hematopoiesis after transplant, iron overload, venous thromboembolism, and also specifically monitoring of chimerism for certain populations. So I will not go through this table in entirety, but just wanted to highlight some of the things that we tried to capture here. So we specifically made a recommendation regarding chimerism assessment for patients undergoing transfer for hemoglobinopathy. We also made several recommendations regarding how iron overload should be monitored after transplant. And then also additional recommendations about venous thromboembolism prophylaxis, specifically considering higher risk in patients with multiple myeloma. We also added additional information on patients with inherited bone marrow failures, as they need specific follow-up as reported by previous publications through PTCTC. And then lastly, we included a supplemental table which shows the specific details such as late complications, the risk factors, what to do for routine patient populations, and what to do for specific special populations. And for each of the tables, there are publication key publications that are cited at the bottom, so people can look at them if they need more information. Next, in terms of immunity and infection, we made recommendations regarding vaccination after transplant. We also updated the table at the end for in the appendices regarding the vaccination guidelines. This is a constantly evolving topic, especially this publication was being worked on during COVID pandemic. So we could not make strong recommendations regarding some of those things. However, as we know that this is constantly new vaccinations are becoming available, so there is definitely a need to continue and revise this recommendations over time. And we specifically addressed concerns for patients with inborn error of immunity and how we should be monitoring those patients. This again shows some specific special population recommendations for this inborn error of immunity and multiple myeloma. And again, this is the supplemental table for immunity and infection, just in the similar format as I showed before. For cognitive, psychosocial, and quality of life complications, we highlighted the need for audiologic evaluation for certain population. We also highlighted the need for assessment of neurocognitive assessments especially for pediatric populations and monitoring developmental milestones, and then recommended formal neuropsychological testing for certain populations. And we also included certain recommendations such as comprehensive geriatric assessment for older adults, as that has become really important for this geriatric population. We also highlighted the need for symptom assessment and monitoring of medication adherence, and then also assessment of lifestyle. We are also showing recommendations regarding the screening for mental health with standardized questionnaire, and also addressing the distress and psychological issues related to spouse or caregivers. And then there are several resources at the end for patients that could be shared by clinicians when they are seeing them, so that they can get additional support as needed. We also address the needs that are unique for adolescent and young adult population, because they are going through several transitions over the course of their life, and they need to be monitored closely, otherwise there is a high risk of loss to follow up. So we had a special section on AYA, and also included certain references for the need for the special monitoring of this population. There is a increasing literature on subsequent neoplasm after transplant. Specifically, this paper just came out in 2020 that looked at subsequent neoplasms after non-malignant transplant. So that was a seminal paper from CIBMTR that had to be included in this effort. However, there is a lot of information that is still coming out even after the publication of our guidelines. So it just shows you that there is ongoing need to revise this guidelines, especially with the information that is coming out on subsequent neoplasm after CAR T cell therapy. We try to ensure that in this section, that if the risk is not modified by transplant history, the screening should be done according to what is recommended by a local region and pertinent to their underlying medical, family, and genetic history. But patients should be counseled about SMN risk, and they should be encouraged to have recommended screening if possible. And high-risk behaviors and unhealthy diet should be avoided. So this is the recommendation regarding the risk of treatment-related myeloid neoplasm, how those patients should be followed after transplant. We also have recommendations regarding breast cancer screening for female recipients who received chest-directed radiation or TBI. And then we also have new recommendations regarding colorectal cancer screening with either colonoscopy or multi-target stool DNA testing. Both breast cancer screening and colorectal screening recommendations were revised in last decade, so it was very important to include them in this effort. So what are the next steps of after these guidelines have been published? So as I mentioned, that manuscript publication was just the first goal. There have been several efforts to disseminate this information through various platforms, such as this meeting is one of them. NMDP is very interested in collaborating with us to develop, update their website, also have some webinars through them. We have been presenting at several conferences and other societies, small meetings. And then we are also in process of updating the ASTCT website and mobile app. So this information will be very handy for clinicians when they are seeing patients. And then lastly, we still have a couple of outstanding things to address. One of them is how to translate this information into different languages, so it can be available across the world. And then how can we make sure that this the guidelines are being updated on a regular basis, so that there is some sort of formal mechanism that we can put in place for regular review. There is also a lot of need to understand if the guidelines are being followed by both patients and clinicians, or if there are certain barriers to following these guidelines. We are currently working on a study to understand adherence to this transplant guidelines. This is just a snapshot of the work that we are doing at our local center in Seattle, but we are also looking at adherence and across the country in the US. And hopefully in future, we can also look at other countries to make sure we address barriers for guidelines adherence. We, as I mentioned, we need to have ongoing revision of these guidelines, but also importantly, we need to include other key stakeholders such as nurses, social worker, and other subspecialists who are experts in these topics. And we need to decide how these guidelines will look like, whether we will be waiting another 10 years before we publish it, or it will be done at more frequent time intervals. There is a lot we still don't know about the future of late effects research, specifically how the genetics play a role in this, what is the role of artificial intelligence or machine learning. We also need additional data, including systematic review. And again, as I mentioned, we continue to have newer therapies available for our patient populations. There is also a lot of interest in incorporation of patient-reported outcomes data and how patients are feeling about certain late effects, how to combine data between different registries to increase our understanding on certain complications. And then again, other technologies for continued engagement of patients through transition so they don't get lost to follow. So a lot to do and we are excited to work on these efforts in future as well. Again, this work couldn't have been possible without the help of these collaborators and colleagues. I wanted to acknowledge them once again, and then I will be happy to take any questions at the end. Thank you.
Thank you very much, Dr. Pipes. I would request you and Dr. Perla and Dr. Franco to be online for the question sessions. And sessions open to questions from the audience. In the front, please, the mic. Yeah, I would like to thank all the speakers for the great talk and discussion. My question is for Dr. Haidar. Question about, do you have any data about sequencing data for post-infusion for patients who receive access? In addition, also, if you have any baseline sequencing data, thinking about the
possibility of secondary neoplasm in the future and follow-up.
Thank you for the question. If I understood it correctly, you're asking about NGS data on patients pre and post infusion. We did not perform NGS on our patients. I just want to point out very importantly that none of our patients, either in the TDT program or the sickle cell program, developed any secondary malignancies. Now, part of the clinical trial, we collected samples in the marrow and stored them. But in the event we see an abnormality in the future, but now with the more than 5-year follow-up, we have not observed any secondary malignancies in our patients. So, and we do not perform this testing on a routine basis on patients.
Thank you very much. And while you're thinking of the next questions, there's another question in the front.
Yeah, great talks. Continuing the question about for Dr. Haidar, I've attempted to preserve fertility in your patients.
That's a great question. Again, because of the limitation in time, I did not go into it. We offered and performed fertility preservations on every interested subject in our study. Actually, the clinical trial paid for fertility preservation, either egg retrieval or sperm banking, and we have performed that on every individual. And We should actually shortly be presenting some data on this, but we were able to successfully collect oocytes or sperm on all patients.
I have a quick question on the same line. What do you tell the patients about fertility after getting the gene therapy? Do you tell them there's a period of time they cannot have any offsprings, or is there no time limit? What are your thoughts?
We do not restrict any. Clearly, while they are undergoing the therapy, we recommend birth control and preventing pregnancy during therapy. But after the infusion, we counsel patients that this therapy does not prevent them from having children with beta thalassemia and sickle cell disease traits because they can pass it. But we do not restrict pregnancy, and in fact, we are going to track pregnancies for individuals who go through this therapy. But as you know, that high-dose busulfan can cause infertility in more than 90% of the patients, at least early, and that's why we collected sperm and eggs and stored them. But we do not have any restrictions on becoming pregnant after the therapy is completed.
Well, thank you. That was just to highlight to the audience that this year we met at ICT in Vancouver, all the regulators now that I do, both the regulation as well as clinical PAT cards. And we had FDA, EMA, MHRA, TGA, PMDA from Japan, and many other regulators. So this was one of the most important discussions, besides the fact that we're working on in vivo gene therapies for healthy sickle cell for globalization. And I think there's going to be a dedicated section just before the ASGCT in Oregon CMA, in which we are going to be discussing the fertility issue that you're mentioning right now, as all the regulatory agencies are getting together for a special day before the ASGCT next year. We have this year as well, in which we announced the convergence of globalization of these therapies. And that's why I'm happy that Neil had presented the long-term survivorship. And I think all these things, the gene therapies coming out for many diseases, is going to be a very important aspect that what happens to the offspring for these people. And that's why the 13 key follow-up is very good, like 113. But that follow-up has to be very good when you start something new in the world. Any other questions from the audience? One last question. In the front, please, if I can make a mic. Mother, please. Thank you. My question is for Dr. Eel. Congratulations for the guidelines. This really is most needed in the modern era of transplant cell therapy. Practical question for your local practice, because we do have long-term follow-up clinic, and sometimes it's difficult to make sure that you are on top of everything for this, which sometimes can become busy clinic. So how do you see this? I mean, how do you do this in the practice? How do you incorporate this extensive and comprehensive guidelines into the practice? And what are the challenges that you see commonly in that aspect?
Yeah, thank you very much for that question. We definitely need to understand how the implementations of these guidelines are being done. We understand that all the recommendations may not be applicable across all different clinical settings. However, we have tried our best to ensure that this is applicable with inclusion of all different international societies. Additionally, that as we treat more and more patients, the number of survivors that we follow in our long-term follow-up clinic are going to increase. So we definitely need to look into models of survivorship care. And Dr. Hashmi has actually published on that before. It's very important to look into that again to see if we need to change our practices so that we can ensure patients are getting all the follow-up they need after transplant. And we are trying to come up with some practical ways we can put this in clinicians' hands, coming up with certain checklist or using through this ASTCT app so that it's very handy and it doesn't add more time to their already busy schedules, and patients are still being followed appropriately.
Thank you very much. And if there are no other questions, a very warm thanks to our speakers. We know it's very, very early for you guys in the morning, US, especially you, Dr. Perla, in Utah, but all Eastern time zone, and Seattle as well, Pacific time. So thank you very much for your contribution. And next, I'm going to ask Dr. Asghar to come over for the concluding remarks. And very thank you to the speakers for the session. Appreciate it.
Thank you.
Thank you, Dr. Hashmi, and thank you all again for staying till the end. It's been very great and fruitful 2 days and great discussions. Well, without these meetings, we will not be able to get the update and connect with people at our side and at the international level. So we're connecting with the other societies and moving forward again with the science and that impact our population and patients. Thank you again, and we shall see you again in our next meeting, which will be 25th of October, the Saudi Lymphoma Myeloma meeting in Al Madinah Munawwara.